meeting of the Aneurin Bevan Health Board. We're very pleased this morning to welcome our guests who will be with us in a couple of minutes, but also to welcome Penny as our new independent member. Thank you so much for applying for the position, and we're very grateful to have you with us and bringing your extensive experience of councils and how they work and everything that you come and represent at the moment. So it's lovely to see you here this morning. Thank you. Today's meeting will be recorded and published to the Health Board's website for viewing following the conclusion of the meeting. We have a number of guests with us today, whom I shall introduce as they arrive. We have a number of apologies. Louise Wright, Martin Blakeborough and Tracy Daskovich will be whizzing in and out the meeting as and when she can possibly get out of a rather important review that she's having to undertake. Any more apologies?
Sorry, Anne, I do need to leave at 11:15 for a call with the police.
Oh, yes, that's right.
Okay,
yes.
Thank you.
Thank you. Thank you very much, Jenny.
Chair, just to say Richard Clark will be joining us after 9:30.
Yeah, okay. Thank you. Are there any declarations of interest for noting? No. The draft minutes of the Health Board meeting held on the 22nd of November, are they correct record? Yes, you're happy for me to sign those off? The board business held in committee to note, are you content with that? If we could pass to the board action log review, please, Rani.
Yeah, thanks, Chair. So there's 2 actions contained in the log. One action is complete in respect of a health and safety report for today's meeting, and that's included on the agenda at item 4.5. And then there's 1 item in respect of CHC commissioning. That has been agreed. It's been agreed that that will be deferred, and we will bring an update to a future board meeting.
Thank you. Any questions? No. The report on sealed documents and chair's actions.
Yeah, thanks, Chair. So this paper summarises the application of the Health Board seal, which has been applied 3 times between the period 31st of October to the 2nd of January, and the detail of which is set out within the paper. No actions taken by the Chair on behalf of the board during this period that require reporting, and so the board has asked to ratify the board's comments.
Are you happy to look at that? Thank you. 1.8, report from the chair, very short. Since the last meeting, I've undertaken a number of visits around the organisation in very, very pressured times for the staff, and I have to say that universally, and they didn't know I was coming, universally they have been very positive, very calm, very, very professional in the way in which they were managing the patients. Having spoken to a number of patients as well, the patients felt well cared for, looked after, and content with the care, even in the most pressurised of all our areas. So I was very grateful to the staff and to the patients for their forbearance in difficult times, and the pressure is quite immense. So I've undertaken my usual range of meetings, but as you know, I've been appointed as the chair of the Ministerial Advisory Group on Governance and Accountability, which is heavy going, I have to say. There have been 3 meetings of the group, and I'm very grateful to my colleagues on that group for the care and attention they're paying to this. And let's hope we are able, by the beginning of March, to provide to the Minister a sensible way forward and how we might adapt the arrangements that we have, learning from other countries and our own on our own learning. I've also got 2 round tables coming up, one with national committees like Dunifield and the King's Fund, to gain their views on the issues relating to the Welsh governance and accountability system, and one with the more local Welsh organisations. So I hope they will be fruitful. I've also undertaken 16 bilateral meetings with leaders of the opposition, ministers, first ministers, special advisors, and I have to say, they were all confidential, obviously, but I've been very, very grateful for the help and support that they have been providing and the sensible questions that they have asked and ways forward. But it has been fairly onerous, I have to say. I also attended and chaired the RPB meeting and the leadership meeting, and there is a leadership meeting with the Minister this afternoon, but it's unlikely I'll be able to get there. We're still discussing the RIF and whether or not we are able to prove that it's providing a value for money and good quality sustainable services which meet the needs of the population, because we will have to take salient decisions on whether or not these schemes continue if they're not delivering what was anticipated, and whether the money would be best allocated elsewhere. There is also a discussion going on about the tapering of the resource, because as you will recall, the resource was put in by the government to pilot innovation, and once the innovation was proven to work or not, then the money would be withdrawn to go to another area. But as we all know, the financial situation is pretty dire for everybody. And there is a discussion with them to be held with the Minister about whether the money will be tapered. We have asked for a decision to be taken expeditiously, because it will have to go back to the statutory bodies to decide if that is the case, what schemes do they stop? How do they release and redirect the resource? And this is a very, very tricky time financially for all the local authorities as the statutory bodies and the health board. So that will be a decision we really need quickly to be able to make the right decisions for the populations. And we will do it collectively as statutory bodies. So that is a really difficult issue that is being tackled at the moment. The Public Service Board meeting, we are continuing collectively to take a lead on developing Gwenter's Marmot region. The needs assessment is proving to be very helpful, but I have to question myself why we have two area plans and two sets of needs assessment, and whether or not you could just have one shared between the RPB and the PSB, because it seems nonsense. It's the same population. The emphasis might be slightly different in the two bodies, but nevertheless, I think we could certainly save time, effort, energy, and be working off the same platform a little more easily if we did that. I also chaired the chairs group, quite a difficult meeting really for the chairs, with the huge problems of the resources available to us to deliver care. We are united that we'll share our solutions together, but nevertheless, it is perfectly clear that we will have to reduce the level of service, but we have to be very clear about what is the baseline service for our population, so that there is a guaranteed access for all, and that we don't play the postcode lottery between the health boards, which would be quite unacceptable. We also discussed the whole issue of the rise of infections and what we can do collectively with Public Health Wales to improve the understanding of the consequences of infections rising within Wales, well, in fact, everywhere. And as you will have seen on the media, there's been a lot of attention paid, certainly to measles in the last couple of weeks, which is helpful and important. But we have to go further. I also had a meeting with the Minister, together with Paul Mears, who is the lead chief executive for the chief executives, about money a couple of weeks ago. So the Minister was very helpful, but everybody is on the same page about what the scale of the problem is. I finally attended a meeting of the Care Action Committee, which the Minister has pulled together to look at delayed transfers of care, community support and nursing services, and the whole issue of trusted assessors to try and smooth the path through the systems, both local authorities and ourselves, for the patient and their carers. And further work is being undertaken on that. So it's been a pretty busy couple of months, but nevertheless, I'm very, very grateful both to the team here and to our staff for the really excellent work that they're doing in quite tense and difficult circumstances. So I'm very grateful to them. Are there any questions? No, thank you. Chief Executive's report.
Thanks, Chair.
It's been even busier, I have to say.
I'm going to keep it brief because I've been told I'm supposed to rest my voice, which is not easy.
You'll not be that way.
Yeah, firstly, I just want to acknowledge, the last 2 months in particular, how busy, our system has been across all the sites as we've managed the pressures of winter. We have seen those spikes in respiratory disease, and it puts intense pressure on our staff and our system. The teams have been working exceptionally hard, and as the chair said, myself and the executive team colleagues have been out and about, being quite visible, trying to be supportive, and making sure that we offer the support that the teams need. But the significant effort is incredible, really, and trying to balance the demand with the workforce challenges and the financial challenges. It's been quite exceptional, but they continue. We've done a kind of midwinter review in terms of all of the actions that we had taken to make sure they're working and having the impact we're expecting. And we have seen areas of particular improvement with the work we're doing with the regional partners and local authorities in a number of areas. So it's really good to start seeing some of those take effect, but we still continue, including today, to be under quite a lot of pressure. And we are quite, worried about the pressure that puts on staff. So we continue to work hard to support that. I think the agenda today very much sets out the scale of change that we are trying to drive through across the health board. And I think as we go into 2024-25, and we're obviously doing a lot of planning at this stage now, I think we've got a very clear line of sight about the forms of improvement. And I feel that we're in a better place and better established and structured to take forward many of those changes we need to intervene, particularly around our six goals for urgent care, and also our planned care. I think it's probably worth noting there was an announcement yesterday about a change in our escalation. This is a quarterly review by the government of escalation and intervention arrangements of all health boards. And there were a number of changes across different health boards. And for us, we increased our escalation status around planning and finance, primarily due to the financial challenges that we are aware of and we are prioritising as a key area, and also on performance and outcomes, particularly around urgent and care pathways at the Grange, ED, particularly linked to ambulance waits and assessment times. So whilst I think it is disappointing to be escalated, I think we absolutely acknowledge those areas of pressure. I think they're two areas that we have absolutely identified as priority areas for improvement. They're two areas we've put enhanced management arrangements in. So we've strengthened our financial governance already around Balance Sustainability Board and some of the control environment. And we've also put enhanced arrangements in around emergency care and the safety flow programme and the work we do in to constantly review ambulance handovers. And we'll welcome the support, the additional support Welsh Government can offer us in terms of trying to drive that improvement. I think I also wanted to pick up particularly around planned care. So in amongst all those pressures, we are trying to reduce the long waiting lists and the backlog of patients, particularly those waiting over 3 years. And the teams again have worked exceptionally hard to try to get us to an improved position, and that comes up through the performance report later. But we had a target. We were trying to get to 0, but we got to 44 patients at the end of December who waited more than 3 years. They were all in orthopaedics. I think all spinal patients, where we've obviously got a major capacity shortfall. But when you look at the always picture, we had the lowest number of patients waiting over 3 years by some, really. And I think reflects the efforts of the teams in trying to maintain that now as we go forward, so that no patient will wait more than 3 years for anything, which 3 years sounds horrendous, doesn't it? But there are cases where patients have been waiting 4 or 5 years in some places. So absolutely committed to reducing. Again, just we had a number of specialties, and lots of those specialties have now trained all of those 3 innovators, which is. I think just picking up some good news. So alongside the intervention escalation announcement yesterday, the Minister formally announced in the Senate that our ED extension has been supported and funded, and that will be part of our solution to improve experience and outcomes at the Grange ED. We also opened the Tredegar Health and Wellbeing Centre on Monday, which is great news. That's been a really key project for us around a kind of primary care integrated wellbeing hub programme. So great to see that open. This phase 1 is open and then phase 2 is now underway. So looking forward to going up there to see it in action, seeing it's a beautiful facility and a really important one back in. And the breast unit is also due to open, I think next week. I know it was delayed about a week because of some technical issues around ventilation to make sure there was no risk, but you know, an imminent point and such an important development for breast services and patients for a one-stop shop. So really looking forward to that being open, and again very timely today's patient story as well. So I just want to formally thank everybody. So the one area I didn't mention, which I can't believe I didn't after last week, was the industrial action. So in amongst all of that, we had a 3-day industrial action with our junior doctors last week. The amount of planning and effort that went into that by our operational teams, as well as our actual clinicians then in terms of providing cover, was quite immense. And I felt really proud of the position we put ourselves in terms of the planning. There was lots of difficult discussions leading up to it, but it went fairly event-free. Our teams go together and we continue to offer. And we did have some disruption to our outpatients and treatments, but again, relative to some areas, we managed to continue with a lot of services. Again, I want to just formally acknowledge and thank the teams that have managed to winter pressures, reducing waiting lists, and dealing with a 3-day of very significant industrial action over the last couple of months.
Thank you, Nicola. Are there any questions to Nicola?
Well done.
Okay, thank you very much. Might I move 2.2 patient story up the agenda, please, and welcome our guests, Tanya and Gail. Important of all, it's nice to see you again. Thank you very much indeed for agreeing to share your story with us. Would you like to come to the table? Happy to stay where you are?
I'm happy to stay where I am.
Yeah. Everybody can see me. Yeah, we can see you. Yeah.
We can see solitaire.
Fine, thank you. Are you going to Tanya?
So I'll open up and give some context. Gail's story is around accessing cancer services during the pandemic. And everybody will know at that time it was difficult for everyone, but Gail went through everything she did alone. There was no visit, no one could accompany her, not even to the diagnosis. Gail's experience didn't come through the normal route. It didn't come through a complaint. It was an opportunist, a private message on Facebook with a picture of Gail sat alone in a waiting room in a mask. And Gail is a retired NHS nurse, so we've known each other for some while. And what Gail talked about resonated with actually the national picture that was coming through, particularly from the then Community Health Council, who'd surveyed people about access to cancer. Your story came to board, it was, I believe, July 2021. And what was acknowledged was that although Gail's physical needs were met, very much met, the diagnosis wasn't missed, the treatment wasn't missed, the psychological distress was. So we brought the story to board. We decided then that we needed to do something to improve psychological support for people living with cancer. We held a little stakeholder group. What can we do? Based on the feedback that Gail had given us, we put a proposal into NHS charities together to improve psychological support across Aneurin Bevan. That was approved by Cancer Board. We were successful and received a grant of £300,000 to introduce a psychological model. I think it's gone far and above what we expected, extremely positive, and Gail won't accept, because she's too modest, the changes that her story has enabled us to bring about. So I'm excited to be here. Anne's excited. Gail's nervous. But I think it's all credit to Gail, because had she not had the courage to tell us her experience at that time, we may still be struggling. I think the other thing to note is it was very hard for the staff to hear that story.
Yes.
They had tried so hard. You know, they did try hard. And those of you that haven't seen the story, I'm willing to share it later.
Thank you.
I think it's more important to hear what we've done now. And Gail, your feelings on what we've done, really.
I was so proud and honoured to hear that my particular story, however negative it was, that there were such positive outcomes from it, and that lessons have been learned and people do need this help, support, etc. Because I felt quite a confident person in my own right before my cancer journey, but going through cancer and being on the other side is so different, and going through a pandemic was horrendous, where there was no help, no psychological help, no one at the end of the phone. I couldn't even see my family. My daughter was nursing and she couldn't come and visit. My other daughter was pregnant and she had COVID. It was just my husband and myself for months on end. And with no help psychologically, I really struggled. I did, as I told Tanya, I went to the radiotherapy sessions, and I broke down crying, and I said, I'm really struggling. And they said, go to Maggie's next door, they'll help you psychologically. And I went round and knocked on the door, and sadly they shut the door in my face and said, it's all online. And I can't work online. I'm sorry. I tried, but I failed. And I think it was an awful experience, and to hear such positive tales that come out of such a negative story, it's just wonderful. Can't thank you enough.
No, thank you.
And I can't thank you enough, Gail. So
Getting emotional now, and I'm usually quite strong, and I have got over it. It's taken me a long time, but I am back to myself, I can assure you. Thank you for inviting me.
So thank you, Gail. And if we can move on a slide, I think, you know, what Gail, what you said at the end is that, you know, the physical of cancer was treated well. So your physical needs were met.
Yes.
I know we've talked about a few, but they were definitely met. But you felt that your psychological needs became undetected for far too long. People didn't notice them. There were cues, and as I talk more to Gail, there's more and more cues that I hear. And then, you know, she said about Maggie's and the door being shut, and then I think you were advised to go onto a breast care now course.
Yes.
But they, you know, shut you out of the Zoom call and things like that. So, you know, everything that you try to do to, you know, help yourself to self-care, which is what we want patients to do, actually you didn't have the opportunity because things were shut.
Yes.
And so I'm Anne May, and I'm the strategic lead cancer nurse. So with Gail and Tanya, we've been working together on this project and what we've done. So I think the first thing I wanted to do was this just Gail's story. And there's some evidence there that I'm afraid it's not. Others are affected by it too. So the All Wales Cancer Patient Experience Survey, we had 1,200 patients answer questions from Aneurin Bevan. Up to 50% of our patients said they didn't have the health and wellbeing support they wanted. And then there were some comments, some qualitative comments in that survey. And there's just 2 quotes. So, you know, I wasn't prepared for the psychological impact of cancer. And then another patient saying that I just underestimated how difficult psychologically this would be. So, you know, there's, you know, further drivers for change. So if you move on a slide, I think, Tanya, you've covered some of that about, you know, what we did. So the scoping and involving stakeholders. So I think we've covered that. So we'll move on a slide, please. And then, so we began to look about what was needed and what would a psychological model look like. And I think for me, you know, we went beyond Gail's story, if that's all right to say that, Gail. So thinking, because Gail, you said it, you were a confident person.
Yeah.
You were a healthcare professional. So how are those people feeling that haven't got the confidence that Gail had? How, perhaps don't know how to navigate our service? So we started to look at, those, to trying to have equity. So we've looked at people with sensory loss, deaf. We've looked at the LGBTI plus, I'm sorry, I don't always say that properly, a population. So those that, we know from evidence don't often access the services that they should, and what difference could we make? So if we move on a slide. So this is what the programme we came up with, and I think it is in your so in the S-bar that I wrote, and I know it's quite a busy slide. And I can't see it from here, but I think I know it very well. So if we go from the left, it's first about access. So Gail's story told us that, and I'll give you the example of your breast care now calls. You were asked to go on a Zoom call. Gail hadn't done Zoom before.
Never. I didn't know how to access it.
And then you went on it and they muted you, didn't they? And you didn't know how to unmute. And so but post-COVID, we're using more virtual workshops, more virtual platforms to deliver care than what we did pre-COVID. So we've introduced a digital inclusion officer who will work with patients and train them how to use digital platforms. We're also looking at IT loan schemes. So that person only started work last week, so I haven't got any outcomes from that. But there's a hope that we can actually assist patients to access. There's also about for our staff to be aware of how to train patients to access. Are we actually assessing what matters to a patient and what their skills are, and how we need to help them self-manage? Then moving on to the heading with the green column, we've also looked at more sort of targeted support. So, obviously earlier on, about the financial pressures in the organisation. And prior to this project, if someone wanted a psychological support, they tended to go straight for a one-to-one consultation with a psychologist. Well, that's quite expensive. And is there a different way to do it? So we now have two groups set up and two more in development, whereby groups of patients, so six to 10 patients, join groups and learn skills, so managing uncertainty, coping with fatigue, mindfulness. And actually what we find from that is that actually it's working with patients and meeting other patients with cancer is really important. Would you agree with that, Jen?
Definitely.
Yeah. So we now offer that. Then the next column is, again, we've talked about, efficiency in our system. We've talked about, does healthcare professionals need to offer this support? And I think, Gail, you had talked about that you weren't able to go and have a coffee with a friend.
No, nothing. Months on my own with my husband.
So what could we do about that? And actually, some people don't want to burden your friend or don't want to talk to their family. I
couldn't burden my family.
So for that, we've looked at volunteers. Experts by experience. So we've now recruited, I think it's 25 volunteers. We've got expressions of interest up to nearly 40 of volunteers that will come and work with us and be befrienders on the telephone. People who've had cancer that will talk to others that have had cancer. We have also then developed a cancer cafe, which you've been to.
Yes.
And yesterday, a cancer cafe in Abergavenny had 7 attendees who were talking to each other about their experiences through cancer. But of course, the blue column then, what is really important is staff, because what Gail said was that her psychological needs went undetected. So, we need to upskill our staff in how to detect, distress, how to manage that. So we've been doing a lot of skills training, and not only amongst cancer staff, but now across, the organisation. So for ward staff, yesterday, physios attended some training. So a lot of training. And then the last column is again about who else is there out there that can support patients. So the third sector offer a lot of support, but it was ad hoc. We weren't coordinated in the way that we deliver it. So the project looks at, using Macmillan, Tenevus, Maggie's, and other charities to support patients. And then if we move on a slide, So, you know, how did we do it? So, you know, it's about the skills, ability, motivation and opportunity, and we need those four to work together for improvements to work. And key to that has been a project manager that was funded by the money that we received from NHS charities. And if we move on again, so this slide just gives some sort of feedback, and you know, and I think you know, what some of our patients have said, and also some of our staff. And I think at the top it says that one patient said, "I now feel much more prepared to do my job." And I think that's hugely important. So in times of, you know, we're talking about times of stress, staff are under a greater demand. And, you know, if they do detect distress in a patient, but don't know where to send the patient or what to do, you know, that's not good for staff experience. And then, you know, and then I think on the left, there's a case where we've now got a counsellor that we've trained in basic sign language, and a gentleman who's deaf is now having counselling, and he hasn't wanted to access the service before because he wasn't understood. So, you know, there's other good outcomes there as well. And then if we just move on a slide, so, you know, how we're going to sustain the change. So I took this paper to the execs, and there is a possibility that Macmillan would continue to fund the programme manager, because I think what is key is, you know, it's the mechanism, isn't it? To keep, if you like, joining the dots of all that's in the programme. So I thank execs for that support.
Thank you, Anne. That was really helpful. Are there any questions? Jenny?
Can I just add that I think, you know, the power of Gail's story in driving improvement and change. You know, we talk a lot as clinical execs around change and improvement and learning and lessons learned. And I think this is a really great example of where experience has truly driven a better outcome for not just Gail, but a whole group of people. And I think, you know, this is very powerful work, but it's also really important work. And I'm really grateful to Gail for working with us after having such a difficult experience and working with Tanya and Anne to put things in place for others.
Yeah, absolutely.
And I think for me, it's beginning to change the culture. And I talked about Tanya that yesterday, because I'm getting more staff coming to me. I've got this patient, I think we can learn from that patient. And that's really warming, because what it's about what matters to that patient. And, you know, sometimes we're doing things that doesn't matter to them, or just quite easily amendable to make a huge difference. And it, you know, and I think if the more efficient we are, you know, the less impact there is on the resources that we have.
Are there any, Nicola, and then
Thank you, and thanks, Gail, for sharing that, and Anne and Tanya for the work you've done. And you know, when we discussed this as executive team, we were really supportive of you know, that importance of psychological support, and I think psychological support broadly across many conditions is becoming so much more evident. And we miss that bit. We do the clinical bit and not support that kind of wider psychological impact conditions can have on. So I think we've got this clear, you know, progress around cancer, but it's how then we take that into even other conditions where we know there's you know, a big psychological impact. I think, you know, also the volunteering work we've done, and I think the peer support, you can't underestimate the value, isn't it, of that, making the connections with people who've been through exactly the same as you and can relate to you and can share your experiences. And again, how we can facilitate that through those networks is really key, and I know gives huge value to kind of people who've been through those types of, you know, services. So thank you.
Thank you. Helen?
I just want to say thank you very much, Gail, for sharing your story originally, but also for sharing it with us now, and for obviously being involved with this project to help the clinical team, for Anne and Tanya, to get this project up and running. You know, having been worked on the other side as a clinician, I think the more ways you can get psychological support, and doesn't have to come from, you know, the nurses in the team, as you say, you've a lot of peer support that's come through that, and certainly, you know, it doesn't necessarily, certainly probably doesn't come from the doctors. It's more from the nurses and the other members of the team. So the fact you're training up people as well on the wards to be able to support patients, and particularly your volunteer groups. So it seems a fantastic. So hopefully you can get the additional funding for somebody to coordinate it and continue it, so that there are things available for people, lots of different needs of people, and you know, different cancers, but also people react in different ways.
Yeah.
Lots of people like one-to-one, but other people don't. And some people want to use online things, but others want that face-to-face. So thank you very much to you all and for taking the time to share it with us now. Very encouraging. Thank you.
I just wanted to say, I think that I think it's incredibly brave of you to come today and say to us exactly what happened. But what is clear is it's about making a difference.
Yes.
And I think your particular situation, which could have led to all sorts of different outcomes for you, I think today coming to talk to us and taking on board all the improvements that have been suggested, all the ideas, I think you'd go away and think, I've made a difference today.
Yes.
And we greatly appreciate the fact that you've come to share that with us, but you've gone that stage further. And as a result of that, others will benefit.
Yes.
I think an opportunity to say thank you very much for coming and sharing that.
Thank
And I think we'd all reiterate that. It's lovely actually for a board to see something happen so quickly as a result of a really very distressing and difficult story. And that, you know, I'm grateful, very grateful to you, particularly grateful to you, but also to Tanya and Anne, who have taken this up and done something about it, which is grand. I just wondered whether or not we were thinking or have already thought about what psychological support could be provided to the main carers of somebody going through, because that also is extremely difficult. And if you don't know how to manage it yourself, you can't help your partner. You know, that's quite important.
Yes, and I think there's what's the definition of a carer? I think, Gail, I talked to you. We also now have a patient panel that comes to the cancer board, and the lady on there with breast cancer said, I could deal with myself, but I couldn't deal with my husband.
Yeah, exactly.
You know, she didn't need care. But she actually then found the cancer person was in a carer's role.
Yeah.
And you talked about that, didn't you, Gail?
Yes, I felt I just couldn't offload on my husband because he wasn't coping.
Well, exactly.
Couldn't speak to my daughters because they weren't coping, and there was no one.
Yeah, exactly. That is my point.
So
Yeah, how do we
that's
support?
definitely a next section is looking about how to deal with those close to us. Deal,
Yeah.
it's probably the wrong word, isn't it? You know, how to support those close to us.
Yeah.
But I think there is something as well about caring, isn't there? And about the carers, especially when patients have got more physical needs, and you know that spouse or that close or family members find themselves as carers. So that will be included as well. So there's lots more work to do. This is the beginning, isn't it?
Yeah, because sometimes in a cancer ward, you're told, right, they're going home. Here's the kit. Apply it, and you think, well, how do you do that then? No, sometimes that can be difficult.
Carers programme is really important.
Good, lovely. Well, thank you so much, Gail, for coming, and thank you for having the courage. A couple of years ago now,
Yes.
tell us the story. You're looking absolutely brilliant.
No,
Have
thank you.
you say? So that's good.
Yes.
It's a bonus for everybody. And thank you again, and thank you for listening and taking this up.
Thank you.
Thank you.
Thank you.
I know, I was concerned, but
I know. Thank you very much. Thank you for doing so much.
She's on the floor, but
Oh, well, that was real good news. I'm very, very pleased about that. So shall we move ourselves backwards to 2.1, the report from Tice and Gemma? Can I just say, Gemma, it's really nice to have you back. We have missed you, although your colleague has been excellent support for us, but it's very nice to have you back.
Thank you, Chair. Thank you, everybody.
You're on mute.
Oh, am I here? I'm off mute now.
That's on there.
Looks like ours is on. Right.
It's
No.
Somebody put it.
good.
Okay. Well, let's see if we can fix this and move on. We'll come back to you. But, well, I know you're going to be listening to the rest, but we'll come back in a minute. We'll try and get it's our end. The technology drives you crackers, but that's
Some of those strings.
Kelly, can you say something, please? Oh,
He's on mute.
Yeah, can you hear me?
yeah, that's it. Yeah, we can.
Yeah,
Right.
and I could hear Gemma. I could hear Gemma when she was speaking, when you were saying you couldn't.
Thank you, Shelley. Can you turn it down? We'll all be deaf if that carries on. Right. Off you go then, Gemma. Oh. But now she's frozen. No, she's not. Is she? No. No.
Gemma, I mean, if you leave and join back.
Okay.
Sorry.
Okay. Well, let's move on, please, and we'll return to Gemma. 3.1, the charitable fund. Rob, please.
Thanks, Anya. So I've got Mark Ross, who's going to present this. I'm not sure if I can ask him if they'd like to come in. Emma? This doesn't work.
Oh, okay. Thank you.
I'll ask Mark to present. Mark and his team that lead
Yeah.
on the charitable funds. We got quite a positive outcome.
Don't think we're getting on very well here, please, Rob.
So I'll do chat. I do it.
Yeah.
Yeah, good. Okay. So in terms of chat,
I can see you, Rob.
Come on, boys, get your act together. Welcome, Mark.
Hello, can you hear me?
Yes, thank you.
Shall I just get straight into it? Sorry, I didn't get any introduction, so I wasn't sure. Yeah, if I just take
You
through
did get an introduction, but never mind. Carry
I
on.
missed, sorry, I missed that. Charitable Fund accounts and annual report. The Charitable Funds Committee met on Monday and recommended approval of the accounts and the annual report to the board. The Audit Wales have indicate, well, I've said that they're going to issue an unqualified audit opinion, and they presented their report and their annual plan at the meeting. The report found that there were no unadjusted misstatements. There were a small number of corrected misstatements, and the report has made no recommendations in terms of the process this year. So that's all very positive. The supporting documents that are attached to this paper, just so you're aware of what's there, because there are quite a few. So there's a set of annual accounts. There's the annual report itself. Then there's a representation letter which will be signed as well the accounts in the annual report. And then for information is the Audit Wales annual plan and their report, which they call the ISA 260 report, which contains their findings from the audit. And the final thing for me really on this is to obviously that the board are asked to approve the annual report and the accounts, and to note that the accounts and report will be filed with the Charity Commission by the end of January, so by this time next week, and I'll stop there because I'm not sure there's much more I need to say on the accounts, but happy to take any questions.
Thank you, Mark. Do you want to add anything, Rob?
I just think, and maybe Paul may want to comment on the annual report content perhaps, but I'd say in terms of the accounts and the audit, it went very well. We were a bit concerned around the timescales, but it has gone very well. So thanks to everybody on that. And in terms of the what we've done with the funding this year, it's about £100,000 spent on patient welfare, 370 on staff education and welfare. The fund supports the actual charitable funds team operating, which is about 140,000, and we've purchased service equipment to the value of approximately 400,000. So just to get a feel for the board, it's all included in the annual report, which I think, as usual, is a good product. And just to highlight that, thanks.
Thank you. Paul?
I mean, I think it's an excellent annual report which sets out exactly what the achievements have been. And I think equally the report on the financial side of things has been exemplary. And I think from my perspective, I would like to thank Nicola, Rob, Ewan and Louise from the board, and Mark, Estelle, Susan and Alison from the team as well for their superb work, and also to Richard and Kai from the Audit Wales group. The unqualified grading, I think, is incredibly helpful. What I will say, as I think is important, is we've got the charitable funds money available and we need to utilise it to best effect. And I say to all executive members of the team, please think about the charitable funds. It's there for a purpose. Rob has outlined some of the areas of spending, but I think there's more can be done for staffing and for patients. Interestingly, I said to Tanya as she was leaving, if you're thinking about a project, for example, for carers and cancer, etc., there's opportunities to put together projects. We've got templates and I think application and nomination forms, etc., all available. And we're looking, Paul very kindly mentioned about possible online stuff. We're looking to really do a bit of emotional work. So currently where we are, I think it's a very thorough report, very well done to all the team, particularly to Mark, who leads on this as well. So, and I'm happy to take questions as well.
Thank you. Are there any questions, Paul and Mark and Rob? Well, I just want to know, are the support costs a little high at 14%, or is that normal?
It's £140,000. We've benchmarked because we do that anyway, and it's about the same across all of Wales. Mark, I'm not sure if you've got any more detail on that. I know we do look at this every year, don't we? But that's in line with others, and I think we were actually below some of the other health boards as well, if I remember.
Yeah, we did benchmark favourably. The audit fee, also the external audit fee, is in those support costs, which has gone up, which we've obviously got no control over. So that's one of the factors in there that everyone has experienced this year.
Oh, that's a helpful explanation. Thank you, because I thought it was higher than last year.
Yes.
Okay.
Yep.
Any further comments? Well, can I, on behalf of the board, thank everybody connected with the charitable funds, particularly those people who've so generously given resources to us. It's an important piece of work because we must make sure that this is used to the maximum benefit of the patients and the staff caring for them. And we look forward to the next one to see what has happened. Thank you. Can we return then to Gemma and Llais?
Yes, thank you, Chair. Do you have me now?
Yeah, we do.
Wonderful. Thank you so much. Apologies. But thank you for the welcome back also. I really appreciate it. I'm happy to offer Llais's report for this quarter. And I would just like to offer a correction for the top of page 5, please, in terms of our advocacy service update, page 6. The period that we were covering with this data is the 1st of December to the end of December and not the 1st of November. So the data for November to December, our figures were actually greater than what is shown there. But apologies for the small the small mistake by there. In terms of Llais's work at the moment, we are increasing our footprint on our hyperlocal engagement approach to speaking to people in our community. So we've taken a very purposeful step to increase our volunteers' work and our staffing work with engaging the population in community areas. So you will see that our briefings and our reports coming back to services and to execs is very much focused on what we're hearing from people in community spaces and focus groups that we're offering to people to come talk to us. But just at the bottom of page 6, you can see that we've heard some very, very specific points from the community, which has actually directed our national and our local priority themes that have been set until the end of March. I know that it was mentioned by the chair and the chief exec at the beginning of the meeting that people are exceptionally grateful for the hard work that staff are undertaking at a really pressurised time. I know that I repeat that at every board that I come to, but the positive feedback about the care and the support that people receive is still shining through. But particularly people are worried about their waits and more staff needed at the Grange, access to mental health services and planned care waits being a bit too long for them. Which is why we've branched off into a focused project for hips and knees and orthopaedics, because where we're hearing about planned care in general, we're hearing quite a lot about people on hips and knees waiting lists. So that survey at the moment has been launched. We'll be offering the Health Board a report back. But what we know that we're going to hear about, and I think this links back into Gail's very powerful story that we just heard about psychological support, is the wait for people on a waiting list when they're in pain, and that becoming a psychological barrier for them to be able to wait as long as they need to wait at the moment. So we know that we're going to hear that and that we're going to be coming back to the Health Board with some of that feedback. Every year we do our winter patient experience programme, which means that our volunteers are on the ground in the minor injuries units and the emergency department. Again, we're hearing very good feedback about the staff and how they're being, how people are being supported. But we have raised an issue with the executive, with the chief exec's office about some feedback that we had about on-site security support at Ysbyty Ystrad Fawr. So we have needed to come to the Health Board with a really specific issue in the meantime. So it's just with thanks to Nicola's team and office for taking that point so seriously, and we're waiting for an answer in terms of how YYF could be supported further. So I'll take a pause at that point and I'm happy to answer any questions, please.
Thank you, Gemma, and thank you to you and your team and volunteers for the excellent work that you do to support us and to bring very important issues to our notice. It's really, really invaluable. Are there any questions? Paul?
Can I just mention, Gemma, the relationship part of this, because obviously Light is new, and I think that talking to the communications team, they're hugely appreciative of the way that you handle the professional way in which this relationship has developed. I think some work we can look at later on with regard to Abergavenny was evidential of the important role that you fulfil and how that fits in with the board's work as well. So I wanted to say huge thanks for that, because that's really, really important. The second thing is, I wonder at some stage, could you look at the area of children and young people as part of your engagement? I'm sort of part of the team with Kavitha on that as part of that sort of conversation which we have, and I think it would be useful at some point when they have a meeting, probably later in the year, whether or not we can tie in with you on that, because I think that's important to get the views and the voice of young people. And I looked at your papers and I didn't quite see, I saw mental health as a one theme, but I didn't see anything specifically about children and young people. And I think it would be useful to look at that area in terms of activity, and we can help with that as well.
Yes, wonderful. Thank you so much, Paul. We are one step ahead with that also. So whilst we've got high level titles for mental health services and the like, we are undertaking a children's and young people's transition survey with the support of the Children's Board that sits under the Regional Partnership Board. So we have got work underway already with the programme managers in that area, not just to look at transition from children to adults for mental health, but for chronic diseases as well, and chronic conditions, and what that's like to go from, you know, a paediatric setting into an adult setting. So happy to link in with you to discuss what we've already put together and just to branch that out even further. So I'm really grateful for that suggestion, but also the support that appears to be there already.
Well done. Thank you.
Thank you.
Well, to that, Leanne.
Yes, please, if I can, just for board assurance, we also have quite a well-established co-production model in children and young person services in relation to sort of service delivery. So they've got significant representation from within the service when they're looking at that to supplement, I guess, sort of any further work that Clais can add with. And I think just the other thing to say in terms of welcome the hip and knee survey, Gemma, I know Linda has provided some excellent sort of lived patient experience on a back pain pathway meeting with the clinicians that we've done relatively recently. And we're enhancing the information that is available to our patients and our healthcare professionals actually in terms of waiting times on eating well. So I do think there is opportunity, and I'll link with you separately around that for the work that Rich has been leading on around planned care, around information on the website, how people wait well whilst they are waiting as well. So, but I think having that insight would be really helpful.
Thank you. Pippa.
Thanks, and as usual, thank you very much for the report, because I think it gives us a real flavour of what people care about, and that's, you know, it's what we all care about, is what people care about. And I'm really interested about the paediatric transfer to adult services. I think that's a kind of a really key area. And I know Clais is new, and now you're picking up social care. But I noticed the statistics are very weighted towards health and not towards social care. And I wondered if you had any reflections on that, whether it's just that people are getting used to the new system, or whether it's that genuinely people don't have any problems with social care, but they feel they do with health. Because there's a really important situation for us and our patients, particularly on discharge from hospital, where there's that transition from secondary care usually into social services or social care. And also in that prevention agenda, how people should be receiving social care in order to prevent them coming into hospital. So I wondered if you had any feeling of why the statistics are skewed the way they are at the moment.
Yeah, thank you, Pippa. And I completely agree. I think it's legacy from the Community Health Council's days, in that largely, you know, professionals and our stakeholders and largely the public were very aware of our role in the NHS before the 1st of April last year. And also our new colleagues in social care and our audience in social care, we're very much starting from scratch in making sure that in terms of highlighting who we are, what we can support with in our remit. But what we are finding is very, very slow, and it is a drip effect of people finding us when they need us in regards to social care, and us spreading the information when we find people. But when we do our hyperlocal public engagement, that is very much targeted in a health and social care arena, so that our message when we meet people on the street and in community centres is very, very balanced in terms of our support for both. I would expect social care feedback and people's understanding of us to go up over the next few years. But I think in terms of the NHS, it's been balanced that way purely because of how CHCs operated before Clais. And we already had well-established routes of communication in through that route because of that work.
Great, thank you.
Jenny?
Just, Gemma, to come back on the children and young people's engagement, I'd hope that, I think sometimes there is a focus on CAMS necessarily. So, you know, I'd also welcome some focus on the experience of children and young people in physical health services, because I think, you know, it is important we understand the experience in CAMS and mental health services for children and young people, but I think we don't have any real understanding of the experience of children and their families in some of our you know, our physical health services. So that would be welcomed as well.
Yeah.
Good. Okay, any further questions? Well, thank you very much, Gemma, to you and your team. And we look forward to seeing the results of your survey and the work that you're undertaking now.
Thank you.
Could we move to 3.2, St Woollers Hospital consolidation?
Thank you, Chair. As the board will be aware, we've been undertaking a significant amount of activity on our patient safety events around the system. And as part of that work, we, just before Christmas, towards the end of November, early December, identified an opportunity as a result of 2 empty wards in particular in the Gwent site to look at how we progressed a very long-standing plan that we've had from a health board perspective. So just as a reminder of that, those strategies really, as you will be aware, we are outside of our Clinical Futures bed base. The original Clinical Futures plan always had it for the physical health wards to relocate into the Gwent site, fondly now named the Newport campus. And in addition to that, we have an estate strategy, and board will be very well aware of the maintenance backlog that we currently have. And we've got some very specific issues in relation to the St Woollers estate in terms of its age and suitability for our staff and our patients' services. So as a result of that, we have been running under the ELGH configuration work stream. We've identified this opportunity and put in place a weekly meeting to see if we could progress the relocation and repurposing of the 3 community-based wards from St Woollers to Royal Gwent. So the high-level plan, without getting ourselves in knots and sort of the detail of the wards, is that C5 East and C5 West will have 2 of the community wards just relocate there. They will retain their community identity. They will retain their name within that footprint as well. And the 3rd ward that was a surge ward and has been a surge ward pretty much since the Grange opened, Rupera, will be repurposed as a ready-to-go ward. So there are some very good reasons for this. There are significant concerns around the spread of our staff and the services that those patients have in St Woollers, and specific examples of that: pharmacy support, therapy support. At the moment, if a patient needs to transfer from the Gwent to St Woollers, that requires an ambulance journey. And similarly, if there's an escalation, patients have to be moved back and forth from the Gwent to St Woollers for emergency diagnostics, or if they escalate. Local authorities are also split over that and recognising how important a partner they are. So as a result of this opportunity, we've been working really, really hard with our staff side, as well as staff directly. We've put in place weekly drop-in sessions. Jenny and I have, in particular, sort of attended various meetings with the staff to give people the opportunity. I think bear in mind that many of these staff have worked in St Woollers 20 or 30 years, and we've seen how that feels for people, say, for example, coming out of Neville Hall. So we have to be mindful that the change is pretty significant for them, and understandably people were concerned about the change, albeit we've been managing that, I think, sort of very carefully, and as I said, sort of meeting with them, and we've got comprehensive, I think, sort of engagement documents, website to set up, email address, that I think that we've dealt with pretty well now. So the overarching plan and the update that I need to give the board from the paper is that for the week commencing the 19th of February now, the original plan was the 12th of February, but 12th of February is half term, and we've identified there are some gaps in our rosters for that time, and we want to make sure that any relocation and change is safe. But in the week commencing the 19th of February, we will relocate those wards down to the Gwent site, and D6 each, which is currently a medical ward, will become a repurposed ready-to-go ward in the community banner. So overall, there's a reduction across our healthcare system of 24 beds, which starts to take us more towards our Clinical Futures bed base, which we've been outside of for some time. it's really important because one of the big queries we've had from staff is how on earth can you think that taking beds out in the middle of winter is the right thing to do? And I think we've been pretty consistent and honest, I think, in our conversations with staff that beds are not the only currency in how we deliver healthcare, and that in fact that offering additional community support and looking at various admission avoidance schemes, as well as increasing the support on the wards, the appropriate, I'm going to call it processing power, pharmacy, doctor input, nursing and therapeutic input, will in fact reduce length of stay overall, that will allow us to do this safely. Our staff, Anne's reflected it, Nick's reflected it, are exhausted. We cannot continue to spread them across our system. And we know that there's lots of evidence and much more sort of articulate colleagues in the room than I around the impact of deconditioning that has, not just on physical health, but also in terms of the social services impact. So it absolutely, to a certain extent, is probably one of the easiest papers I'll bring to board. It is absolutely the right thing to do. There is the added benefit. Obviously, Nicola's referred to targeted intervention on a financial sort of basis for the health board. There's a full year benefit of approximately £1.7 million as a result of this change, albeit I believe that when we get into the detail, there's more further costs that will come out of the system as a result of things like reduced diagnostics that are not necessary, reduced ambulance conveyances sort of back and forth. So my personal view is that with that closure, I believe that to be a modest estimate. And I know we're working with Rob's team to come up with a more robust sort of model around how we cost and track the impact that these changes will have. We have, I think, we've been moving at pace on this. As I said, that weekly meeting, it is uncomfortable, I think, for our staff on that. But I think that the decision around this is making it and giving people the certainty, I think now is absolutely sort of the right thing to do. We have, I think, just wanted, just in terms of summary now, I think to note the progress and endorse the recommendations in the paper that Rupera moves from a surge community ward to a ready-to-go model that I know Jen's team is leading on. But we relocate Penhow and Gwanwyn, and just finally, because it has been a truly multi-professional, multi-divisional, we have quite a mixed bag of individuals on the weekly meeting coming together because it affects so many people, facilities, staff, as well as therapies and nursing and pharmacy. It really has been a really collaborative team effort. So I just recognise in the time of year we're at and how much extra the amount of planning that has gone in has placed on the teams. I just would really welcome, I think, sort of recognition for the teams in relation to that. So just would welcome endorsement of the paper, please, but happy to take any questions.
Thank you, Leanne, very clear. Are there any questions, Pippa?
Thank you. And I think, you know, whilst appreciating, of course, it does mean change for people, and that's often difficult. I think, you know, bringing teams together is going to result in better patient safety and the quality of the care that they get, hopefully reduced length of stays, all sorts of really good things. So from that perspective, I think I felt that this was something that is the right thing to do. I think it's the expression you used, and absolutely. My question is around what's the other things that are in St Woollers. For example, there's a surgical orthopaedic, isn't there, and Sycamore, and whether or not you have any kind of future planning around this. I'm not asking for a plan, just whether or not there's a sort of roadmap for getting the best out of St Woollers and also making the best out of the Gwent, for example, next door.
Anna's itching to come in at that point.
Yeah, no, I was going to come in anyway on this point. So thanks for the question. It's a say in the paper, it's alluded to that this is obviously the drivers, as Leanne has described, But it does give us an opportunity to deliver on one of our priorities, and the conversations we've had about the plan for next year is that in line with our extant strategy to rationalise the St Willis site. So we actually have a workshop Monday next week to bring together now, so try to bring the jigsaw pieces together, subject to what the outcome of today's decision. We now know we've had the T Gwent investment, which will help us rationalise a number of leases and support some non-clinical staff moving off the St Willis site. So we've got lots of opportunities now to deliver on something we've been talking about for a while. Use it. The moment, again, subject to us testing it next week, around Casnewydd is a good bit of estate, and we would, we can sort of cordon off the site to maintain that, because as you said, like I said, the orthopaedic unit's there. Remove these wards, it gives us an opportunity to maybe expedite at some of the other clinical services there, because the ward by definition is a clinical environment. So we are proposing, we'll know it's a priority in our plan for next year to realise that intent, and we'll bring back a proposal that brings all these pieces together, but none of that sort of stops this. This is a real sort of enabler for it, as is T Gwent. So we'll absolutely bring a proposal around the St Willis rationalisation. Thank you.
By when?
We'd like to have the route map before the start of to include in the delivery of the annual plan.
Yeah.
Until we've had the session next week, probably not wise to put a date in until we've worked that through in the workshop next week, if that's okay. But we'll can update at the planning committee at the end of the month.
Fine, that'll be very helpful. So we'll put that on the committee. Jenny?
Well, I think unless Shelley's first.
Shelley?
Yeah, I just wanted to say that I fully support this. I went to St Willis, I think the week before last, and in particular the old site. It is in a terrible state, and I think they were having to close certain corridors and what have you. So this makes sense, and as Hannah and Leanne have said, this is part of the our estate strategy. So I think this is going to be a positive move for patients and eventually for staff, but acknowledging that there will be some upheaval for them, and also it will mean that we can move people out of the old building to much better accommodation, and also have an opportunity to put people in more appropriate places that probably at the moment don't need to be in St Willis in any event. So I just want to say I support it. Thank you.
Thank you, Shelley.
I just felt I should add my clinical support to Leanne on this proposal, because we all know that patients decondition in our beds, but worse than that, actually patients come to harm. A number of the falls we see, the injurious falls, the catastrophic falls every week, are patients who probably shouldn't be in our system. And I think more beds is not the answer, and actually consolidating to a smaller number of beds allows us to really develop our staff and their skills. It really allows us to focus care on where it should be delivered. So for the right patient in the right place. And I think it gives an opportunity to share and develop skills across acute and community, because one of the things we've found through the patient safety events is that if you're an acute nurse and never worked in the community, of course you have no understanding of what community services are available, or even what's accessible, and how people can live at home, and what level of risk can be tolerated. So actually that cross fertilization of knowledge, skills and competencies, I think, is going to be incredibly valuable. That's not just for nursing, that's for medical staff, therapy staff as well. And I'm particularly excited by the Ready to Go. It will be a demedicalised model. It will be nurse and therapy led, but not delivered. We will look to enhance our band 3 and 4 model through that ward. So we are delivering care that is more like the care they will receive at home. We know it works. We've been to see a model in Somerset, and I think it will make a huge difference.
And you will be evaluating.
Absolutely, we
because
evaluate
it's
everything.
really important. Very important. Ewan?
Yeah, fully supportive of this. I think it's a win-win-win. As we're taking every box going with this one, I think. There are a couple of things in terms of our estate strategy, and I think we do need a plan. I think that is something we have discussed around here in the past. Our estate strategy is considerably out of date now, I think. in terms of where do we want to be in 5 years, where do we want to be in 10 years? And it is that, when are we going to refresh it? You know, it is a question that's been raised here before, of when do we get that refreshed estate strategy? I know it's not a small task at all, but I think it's something we do need to develop so that, you know, these things just become a tick in the box, essentially, then if we know it's in line with what we want to do.
Yeah, agreed.
Yeah, just on that, so I think we all agree kind of the estate strategy, refresh, you can keep refreshing, and we, you know, lots of the things that are in the current one are still very valid, and we know some we've made some good progress on, and others we're not making the progress we need to, and we know, you know, St Willis is one of our priority areas in that, with others to come that we know are of big significance as well. So for me at this point, I want to concentrate the team's effort on delivering a couple of those key projects and getting St Willis, for example, over the line. I think what might be timely, and I've discussed this in is around, we're about to kind of refresh our service strategy, and maybe we can kind of, especially the work we try to do from a capital, you know, the estate that's in other, with, you know, in the kind of primary regional space, and try to pull all of that together as a refreshed estate strategy. So it could be that we time it to follow that, but what we do need to do is probably refresh the pace on some of those ones as an existing one, and that's what I'd like to concentrate on, is delivering the components of the strategy we've got, and distracting ourselves by writing a new strategy. Albeit I think we do need to do it.
Even at the high level of roughly what does our estate look like in 5 years, 10 years, it's not that detailed.
Maybe it's more that
plan.
Vision.
It is more that, right, what do we look like in 5 or 10 years? Do we have all of these hospitals, or actually we have 1, 2, 3, and then we have A, B, and C, etc., so that we know that we are heading in that direction, and that dictates your capital plan.
Absolutely.
It dictates a lot of stuff, and obviously gives you a bit more assurance around how your revenue plans are going as well.
I agree. Leanne?
I just think on that point, it's really, really important we're clear that that has to be driven by the clinical or the service model in the first instance. I think part of the reason we're in the situation we're in is that we've probably allowed the estate to dictate what the service is, and certainly from my experience in futures, if I had £1 for every time, tell me what this clinical model is before they start sort of squatting or sort of claiming rights on space, we wouldn't have the financial deficit we've currently got. So there is a big, I think we've got to keep on with that mantra, describe the service model so that we've got an appropriate then estate strategy that sits alongside that. But that doesn't need to be sort of progressed, I think, rapidly now.
Absolutely.
What are we talking about then?
In terms of,
well, getting the clinical strategy and then the estate
service strategy we're coming on to later in the agenda. I think what I'll link in with Hannah is what we can do in the interim to give a bit more clarity about the direction based on what we know at this point. But, you know, we can do that, and we pick that, you know, we can do that probably in the next, in terms of clarifying the current estate strategy and giving a clearer pathway to the next 5 years.
Hannah, Phil and Paul.
Yeah, just to agree with everything that's being said, and we've talked about in this meeting and the planning committee about the estate strategy. We'll come on to it, I guess, when we talk about the capital paper as well, but when we talk about the estate strategy, some of it, we've got some components that have recently been refreshed. So through the partnership, the RPB, we've recently approved a strategic capital plan where well-being and the hubs sort of concept is sort of features. So it's about how we bring that in. And also we've talked some of the learning and some of the focus we've got in mental health now around how just some of that learning, what some of those challenges are maybe attributed or exacerbated by the estate and the duplication of services. So we need to make sure that service bit around mental health is factored in that strategy. One of the things we talked about the last planning committee, which we've started, isn't coming back to January, but is for each. So basically a route map for each of our current bits of estates, whether they're leased or owned, in terms of what the current working assumptions are around, are these leases, for example, that are going into T Gwent? Is this, is it a St Willis facility, and therefore we're planning to rationalise or decommission, so that we're really clear for every type of estate and from a service perspective as well. And that will show where we've got some either assumptions that we need to agree on, or we challenge ourselves on, or some where we haven't yet got a clear line of sight to what the plan is. So that bit of, sort of work is as we speak.
Good, thank you. Bill?
Yeah, I think this is a tremendous opportunity, really, and it shows that we're kind of into change management in action, really, isn't it? I mean, this is what we should be doing. Picking up on Jenny's point about this is right for patients, it's the right thing to do. And in that vein, I would just pause for thought about really perhaps that we don't over egg some how difficult changes might be for staff, because what we have to do in future is lots of changes that will be much more fundamental than this. And I guess that there's only so much change management in terms of capacity that we actually have. And clearly reading all the stuff related to this, it must have taken hours and hours of people's time for what is a relatively minor change, I would say, in terms of staff. Now,
That's something that had already been agreed.
Absolutely. Now, people might shoot me down for saying this, but it's very easy to sit here and say, well, you've had 150 meetings with people just to do a small change. But of course, these 150 meetings take an awful lot of capacity, an awful lot of time out of the organisation. And I think we need to be careful going forward, looking at the amount of change we have to do. We can't invest this amount of effort in every single thing that we do. And some of those things are going to be much bigger than this. So I think we need to be careful as a board that we're not getting into all of these changes very difficult. So we have to over egg, I would say, in how we do it, really. And then I just think about all of the exec time, for example, that must have been invested in this, which is, to be absolutely honest, it's relatively minor. There will be a lot more difficult that we'll have to grapple with. Just looking at the rest of this agenda, that's going to require much, much more fundamental than this. It's just a thought, really. I know many people won't agree with my thought around it. I just think we have to keep a sense of balance.
Yeah. Well, that's quite. Yes, hang on. Sorry, something to say. We have brought up the whole engagement consultation issue with the minister because it is hugely onerous at the moment. Yes, we've really got to get to grips with what do people think and to engage them properly. But the rigidity of what we're required to do is neither helpful to that process that we want to adopt, nor to basically the outcome that has to be pursued. So we have taken that up with the minister. Sorry, Sarah.
And I think, I agree with those comments, Phil, and we have an organisational change policy which sets out the framework which we need to work within quite clearly. So we, from an employment perspective, we can't get away from that. Yeah. But we have agreed locally what that would look like as a bare minimum with our staff side colleagues, which I think will help us as we move forward. But one thing I've asked the Workforce Business Partner team to work on as we develop the plans for the next 12 months is a map of all our change management programmes, so we can really drill down, make sure that we operate as efficiently as possible, but more importantly, they're very clear and don't confuse the staff in terms of the change management processes that I'm sure we'll have to implement. So that will come forward as part of the programme of changes, I think, for the year ahead.
Thank you. Leanne?
I think thank you, Phil, for the recognition of that, because it is a significant investment in lots of people's time on this. But I think it's important to share. It is really, staff are really wobbled by this, particularly when they've worked somewhere for 30 years. Yeah. They've only worked, their home is St. Willis, and we've seen it in sort of Neville Hall. And actually in the events that we've been to, they've come up with some really good suggestions about how we implement that. And there's a balance of going to engage with them early before the change is set about what that looks like, which creates uncertainty. But I think just for, again, sort of assurance, we will do a debrief after the changes happened in terms of lessons learned and how we improve that. Many of the management team, we've got a relatively, operational management from a health service delivery. Lots of people haven't got this experience either. Yeah. Right. So I think, some of it is in terms of the exec leadership is to provide the support so that we're role modelling what's required and expected. And actually, because we're on a fast track pace from a time perspective, something that might have taken us 2 years or 18 months, we're trying to do in 3 months. So there is a requirement, and whilst it is a relatively modest change, I think it sets a very significant step forward in terms of both the estate's strategy and improvements that we need to make, and some of the patient safety issues and the bed-based issues we're trying to resolve. So I think recognize it is time consuming, but I think it's required, and we will refine and learn as we go on and spread that.
Thank you. Nick?
Yes, just to reinforce, so, you know, I know Leanne and your teams and Jen's team spend a huge amount of time, Sarah, working with trade unions, you're right to say. And whilst I agree, you know, that is for me is how we make sure we communicate with staff effectively and we involve them and engage them, because having a load of disgruntled staff doesn't really help a retention of a workforce that we're trying to hang on to and years of experience. I think the debrief will be really helpful, because I think what we've got to do is look at how we get a slick process. We're constantly looking at how we improve our communication across the organisation, and it's something I'm working on with Karen around staff communication, because trying to get the 6,000 to 15,000 people across the organisation to know everything that's going on is quite difficult, but we've got to keep trying. There is more work we can do on that, and then how we make sure we have the right meetings with the right people at the right point. Like the answers, it's a fine balance about not doing things, you know, kind of behind closed doors before you made a decision, but then not worrying or raising expectations by going too soon. So it is a fine balance, but I think, you know, as Leanne said, that kind of debrief and think about, okay, how do we, and have we got the right experience and capacity to help drive some of the changes we make? So I think there's a lot to learn from it, and how we get that balance between making sure we communicate with staff without it consuming hundreds of hours. So I think, you know, we're constantly working on that. Thank the team for all the work they've done on this, because we are pushing the boundaries and pushing the pace on some of these issues.
Yes. Paul, final comment?
I think what's been helpful, there's two examples within the board papers. One is to do the staff and the St. Willis example, and also with regard to the Abergvenny example. And I think that it's what learning comes out of that. And there's no doubt in my mind, there's got to be some remodelling in terms of, if there's a certain amount of time frame, you have to work within that time frame. And I think there's been the experience or the approach previously is given more time. I think with key decisions got to be made, then it's got to be fair, reasonable, proportionate, evidence-based decision making. And then there's a clear sort of golden thread throughout it. So I think actually what we need to take stock of is what can we take from these exercises to make sure we can improve things for the future? I think things have been said earlier with regard to the St. Willis example, and I think similarly with regards to the Abergvenny example, there's lots we can pick out of that to make sure we can improve things, make it simpler.
Yeah, absolutely.
So, and I support the proposal.
So are we prepared to endorse the recommendations?
Yeah.
And thank you all for the really careful work you've undertaken on this. It is an important change and an improvement of patient care. And perhaps, Jenny, at some appropriate time, it would be helpful if you could just give us a short overview of why the patient safety visits make such a difference.
Absolutely,
so
very happy to do that.
We can make sure that it's rolled out everywhere and that the staff acquire the skills. Thank you. Thank you very much. Can we go on to 3.3, the outcome of level 4 minor injuries unit? So includes YYF.
Yes, thank you, Chair. And as was already just picked up on, there'll be some themes from the conversation we just had in terms of learning for approach to change management and this gender item as well. So the purpose of this paper is just to feedback on the outcome of the extensive engagement around the MIU provision across Gwent. The board will be aware that the proposition upon which we engaged was to consolidate and formalise the reduction in opening hours of YYF that had been instigated on an interim basis through COVID, and also to mirror that going from 24/7 in Neville Hall through to 7 a.m. to 1 a.m. To be clear as well, before we talk about some of the themes of this, the driver behind this proposition was following sort of the insight, intelligence and analysis on demand and how we best use our resources to match demand. And you will see from the paper and recall from previous conversations that in terms of the demand into Neville Hall in that 6-hour period is extremely low, with 1 patient a night, yet consuming a disproportionate amount of resource in terms of clinical staff to staff that service, and that's been challenging. And it's a theme, isn't it, of all our service changes from that best use of resources and how we target those to where the need is. So this proposition came through the division and we've engaged on it. As appendices to the paper, there's quite a detailed report. There's the response, thank you, Gemma, from Llais on the report, and some background information on well in terms of the so just to note that there was a comprehensive engagement. We did, again, some learning here. We did embark on an 8-week engagement process that, following the not insignificant concerns raised in the first few weeks, was extended to 12 weeks. So potentially some learning for us there. We also amended the process as we went through on feedback from other stakeholders. So we had some feedback in terms of reach into Powys. So we adapted, working with colleagues in the health board there, and made sure our reach and our engagement was into those communities as well. So I won't go through all the detail of them, but themes of the feedback from both the online events, the surveys, the petitions, and the conversations in the engagement events were around concerns at access for the person who does need it once a night, concerns of disproportionate impact on vulnerable groups, and concerns about what this meant more broadly for Neville Hall going forward, and also what was a really big theme, particularly in the conversations for those of us who were in them, was around more broadly around just navigation and understanding of our urgent and emergency care system. So less about the MIU in Neville Hall, but more about some of the complexities and just an understanding and what we can do to simplify that. So they were really big themes. There's a lot of detail in the report in terms of numbers and where we engaged in 12 formal events across the patch, but this we supplemented with online and use of our existing engagement activities to reach into communities. But ultimately, the proposal before today is to go forward with the proposition, whilst acknowledging some of those concerns. I think it's fair to say nothing that came back through the concerns or the queries raised have significantly challenged the proposal. What they have done is give us areas that we need to work further on, notably the area I just mentioned around simplifying and being really clear on how the urgent and emergency care system functions. So my last thing I wanted to say, many questions, was just similar to Leanne on the St Willis, just to acknowledge and thank those involved in this. A huge amount of work done from operational clinical teams, the comms teams, my team as well. Also thank the public stakeholders who engaged in the process, and stakeholder partners in other local health boards, and particularly Llais, and I'm sure Gemma will come in to comment, but it's important to note that the Llais letter that you've got in the pack does acknowledge the work done today and recognise there'll be no further representations around this proposal. So I'm sure, so it's keen to just endorse the proposition, but also I think it's important we pick up and do that debrief in terms of approach on engagement as we go forward into what we know is going to be a period of big change over the next few years. Thank you.
Thank you, Hannah. Yes.
Sorry, should I declare an interest at this stage? Yes. I wonder, because we Nicola and team came to speak to us.
I think that'd be wise.
I mean, I don't make a decision on it, but yes. Okay. Thank you. Thank you.
Any comments or questions, Paul?
First of all, I think any proposed change has to follow guidance from the Welsh Government. Otherwise, it's open to judicial review or in terms of the process. From what I've seen, this has been incredibly comprehensive, thorough, and detailed review, which I think all credit to all the teams involved, particularly communications, because I think it's incredibly important that there's all the opportunities have been sought to get people's views. I think it's also received an equality impact assessment, which I've noted, which I think is important as well. If you look at the details, 140 pages of our board papers today, according to my maths, are on this one particular issue. So it goes to show how thorough this has been. Lice has been involved in a very helpful letter from them. And I think all in all, what has been put forward, I think is, in the circumstances, I think it's very reasonable. I think it's thorough. I think it's proportionate. And I think that it's based clearly on the evidence. So I would support the proposal.
Thank you, Paul. Pepper?
Yes, and extensive work that's been done on this. I think for me, there's a couple of things. If you're only seeing one person a night, then actually that's quite difficult to keep your skills up as a member of staff. And my concern there would be that actually there's an opportunity almost to create harm if you've got somebody who's treating you at 3 o'clock in the morning whose skills aren't up to date. And so I think in itself it's a challenge. You know, whilst nobody wants to see services closing, what we need to make sure is that our patients are getting the best level of care that they possibly can. And my sense is very often people will be prepared to travel a bit further if they think they're going to get the right treatment. So I think that in itself supports the overnight closure. But I do think that the key thing in this is making sure that people know where they should go and for what. You know, and I know there's been a lot of communication around accident and emergency services, minor injury services, you know, out of hours GPs, but it is a very complex environment. And I mean, I had a leaflet go through my door some time ago, which was full of lots and lots of words about where I should go. And I do know that there were people who I spoke to who just said, oh, it just looks so complicated, and didn't sit down to read it. So it's about how do we distill that message into, you know, if you cut your finger, you go here. If you think you've broken your arm, you go there. And actually, what is an emergency? So where should people go? So that communication, I think, is not just a single message, is it?
No.
We need to continually remind people of people who have had some kind of an accident or their child is unwell. It's not the time that you're going to be sitting down thinking, I'll pull that leaflet out the drawer and read it. You know, it's at that point when you're in a state of panic that you want to know where you have to go to, rather than having to try and navigate a system. So how we make that happen is really important.
I think just on that, I think it's really important that we don't just communicate how you access the current system. We simplify the current system and then communicate on that rather than all these options, as you said. It's about how do we reduce the number of front doors, whether it's you don't have to know everything because you're going to be directed to through a device or through a conversation about where's the most appropriate place to go, rather than expecting everybody to. And this came really strongly through. What's a minor illness? What's a minor injury?
Yeah, quite.
It's really, you know, even us who work within the system, and it's a strength of feeling on that. And I think we should acknowledge as well, because the report does really focus on MIU, but the strength of feeling from staff and local communities around Neville Hall.
Yes.
And the passion around Neville Hall and the concern around the future
of course.
Neville Hall. I think it's important we sort of acknowledge its in its future role in our offering. So
absolutely. And on the navigation of this system, you know, we have got to ensure that 111 works really efficiently and people understand that that is their helpmeet, that's where they go if they're not sure, and it's responsive and it doesn't take hours to get through, and then people ring you back in 4 hours and all the rest of it. It's got to work really, really well, and we've got to make it simple for people, because, you know, in a panic, you go to the nearest place, don't you? And if it's shut, well, where do I now go? Which is an awful situation. So I think that's really important.
Thank you.
just building on that point really, and I think some of the early discussion about our clinical strategy and thinking about our future as a health board, I think it's really important that we actually understand why people in our community behave in a certain, and move away from this perhaps approach we've taken in the past of saying somebody's gone to the wrong place, or they've done the wrong thing, or they've not been compliant, and changing our language that is a lot more about understanding people and why they behave in a certain way, and very often because they're fearful or that they're in pain or whatever. And if we can tune into our community better and develop services that meet their needs or their fears or their worries, I think we'll be in far better chance of succeeding and won't fall into the mistakes of the past about saying somebody's gone to the wrong place or this isn't right. And there's a lot of data we've got in the past that tells us about how people choose to behave or where they go, and we must look at the data. But I think importantly, we must continue the conversation with our community as well to really understand that. Let's not work against them, let's work with them.
Absolutely, Peter, dead right. Gavin?
Just to echo those thoughts, and where I want to steal the thunder from the next item on the agenda, I think as part of some of that is what's sort of actually around long-term strategy and the design principles for long-term strategy. There's a lot we can do to make things simpler and easier for people to understand, and understanding why people make decisions, to make sure the services are designed around what it is people are trying to do, and rather than in a specific way.
Yeah, absolutely, absolutely agree. Helen?
Just a minor question. I'm just interested, obviously YYF closed from its 24-hour service back in COVID, presumably with no consultation, no warning. And are there any lessons learned? And has it stayed shut for the last few years?
Yes, so as part of the decision we're seeking today is to support that. I mean, moving from, it was done as sort of an urgent change, as lots of COVID changes were, and this is us trying to ratify that to make it sustainable. Obviously, as part of the planning work and the consideration work, was looking at so what's been the impact of that? Has there been a disproportionate impact of demand going elsewhere? Picking up Peter's point, but sort of inappropriately, or and there was nothing in that the evidence. So we had sort of evidence really around what had already happened with YYF, but this paper does seek to, as I said, substantiate that decision and to move to it with Neville Hall. Okay, thanks very much. We did engage with the YYF communities as well.
So the recommendation is that we approve the outcome of the engagement from Neville Hall Hospital MIU and ratify the changes in YYF, minor injuries. Are we content to do that? Thank you very much. But we must not forget about the navigation of the system, and it's got to be simple and it's got to be understood. So if we could have a small report on that pretty expeditiously, please.
I suggest you agree, Nicola, and we put that into the 6 goals work, because there's lots of developments. It's just, I think we can.
But their board will require assurance.
Yeah.
That this has been simplified and we can take it forward. Lovely. And we will also look at the engagement consultation processes, please, as well. Thank you. 3.4, the long-term strategy design principles then. Hannah, please.
Yes, thank you. You've been referred to a few times already, and in terms of we've already made a commitment as a board to develop a new strategy, engaged as a board in some thinking and shaping in a sort of a pre-engagement phase. And this paper seeks, as you said, support for the design principles that will be really used to help shape our conversations with stakeholders and the public, so that some of our framing, our messages around what's, we talked about this, about needs versus wants, around expectations, around reality, around resources. So these design principles have been have emerged, from our engagement session we had as a board. We did a similar session with the senior leadership group, so execs and divisional triumvirates and deputy directors. So this paper just sets those out and reminds us of the timelines, but it does set out the 10 design principles that we are proposing to use to shape that engagement. Just a couple of points. I won't go through each one individually, but what we have tried to do, interested in whether we succeeded, is try to think about language in language that's accessible and means things to not just us in NHS jargon, but means something to our population. We will obviously get quite immediate feedback on that as we test these and try to use these. So, and we will iterate these if they're not quite in plain English. We've also set out, again, a theme from the last two items, but if we're committed to doing this meaningfully, and I think we talked about this previously, but the process of engaging with this will be as important as the product, or more important, I'd argue, the product itself, because of that ownership, understanding, shaping. And if we're committed to doing it in a way that's engaging, we're going to have to put some resources behind it. So it will be, as the paper sets out, parts of my team, Tracy's team, Karen's team around their priorities for next year in engaging and leading and freeing up this work. There's also a small impact in terms of materials that is set out on one of the pages there, which we've identified a budget within the organisation to pick that up in. But I just think we've previously been asked and challenged on what resources to do this. It's about reprioritising, assisting, and also set out there some additionality. We'd also welcome any involvement that independent members would like to provide over and above through this group and the steering group and the engagement events. So lots of work still to do. We've been working through the steering group that David chairs, I'm sure will come in now. But the main purpose, as we said, is just to get some feedback and agree with these design principles to help us move forward. And final point I'll just say is we're already starting to use these or versions of these for some of our other work. At the planning committee at the end of January, I'll bring an update around the RAC work and the Neville Hall work, and it's a version of these we're using to frame that as well. So there's an opportunity to get some consistency in that approach as well. So I'll pause there. I'm happy to take any questions.
Thank you, Hannah. David?
Yeah, I just wanted to just sort of add to that, these, my hope is that these design principles will help guide other decisions and some really good decisions to turn out long-term strategy. These are probably heavily influenced by principles that exist in other organisations. Both NHS England and UK government have got very similar principles for how they design public services. There's some really important ones I want to just call out, partly to begin with, starting with putting people at the heart of everything we do, as we just talked about in terms of the MIU conversation. We need to make sure we take time to learn about what people are trying to achieve and what they're doing, and make sure we base all of our decisions around that, rather than sort of making assumptions. Things around designing with data is really important, and making sure we use actual data to make decisions rather than hunches and supposition. And then things around making it really simple. People don't understand. Shouldn't have to understand how our service works, and we need to make sure that what we design and what we deliver is really simple and hides that complexity from individuals who quite often in crisis and don't need to understand the detail. And then the final one I sort of just wanted to pick out was things around transparency and making things open. I think we've learned from the work we've done with Neville Hall that the more we are open about the challenges we face and the data and the way we use, people respond to us. And I'd like us to encourage us to continue to do that on more pieces of work and be as open as we can. So I think these principles, I think, will really help us in terms of developing a long-term strategy, but also in other important decisions that we make over the next few years.
Thank you, David. Thank you for agreeing to chair the steering group for us. Rob?
Yeah, I think we discussed previously about adding one of the design principles was potentially living within our means. For example, providing sustainable, high quality care within funding available to the Health Board.
Yeah.
I think that's absolutely essential where we find ourselves currently.
Yeah.
The longer term strategy, Salvia's suggestion, I think that we added in.
We did add one, just tweak the language after testing. It's around around resources available. I'm
not sure it's explicit enough, but happy to have it.
Okay. So we did add a 10th on the back of that, and just tried to check the language would be So it's absolutely the intention to make, because it's a really important point that we are honest and transparent with the public around what is actually achievable and how we get best value from the resources we've got, which is how we try to sort of frame that. But it's not quite hitting the mark, we can tweak that.
Because it can't be achieved at all as a strategy if we can't afford it.
Absolutely.
It's misleading, isn't it? Well, that will be added.
I think one final thing to sort of add is there's two of the principles in this. Continuous feedback is one of them, and that's nothing should ever be static, and things will always need to change. That applies not just to our services as the world moves on, but also to the strategy itself, to these design principles. We need to test and learn from everything, get feedback, and then iterate and change these as we go along. If these principles need to be tweaked over the next few months, over the next few years, then we should be able to do that. I think that's going to be really important. And as the last principle on this says, this is just a start. There's more of this that we need to do. This is going to work doesn't end; it has to keep going.
No, thank you. Are there any further comments?
Just briefly, though, I think it's page 203. I think it's mentions independent member involvement in engagement activities. And speaking for myself, I'd be happy to be involved. But
we need a jolly good. Everybody needs a good script.
Yes, but this is something
that would need to be worked.
How you work with all of us to make that happen.
Yeah. Thanks. Anything further? So we endorse these principles and the work to date. The capital plan, you're going to be hosting it.
Voice line first.
Yeah.
Thank you. So I appreciate this is quite a hefty paper. We have tried to model it on the paper we received January last year. And so what we're presenting here is a draft capital programme for next year. And the purpose of bringing it now, rather than wait until March when we've got the plan, is to really put us in a good position to take advantage of any end of year opportunities that emerge if we've got a programme that's agreed for next year. And as has already transpired, Welsh Government say, anybody got any ideas for how we can spend money this year? It enables us to bring that forward and be really agile and take maximum advantage of that, both any of our own slippage or of national slippage. So that's why, if it feels a bit, why are we doing this now when we haven't got the plan yet? And whilst I would say, so whilst this will help give us that draft plan, we know from experience that things will change. There will be new opportunities, but there will also be new risks that emerge throughout the year that we will need to manage and manage in terms of how programmes deliver. We reprioritise throughout the year, so it gives us a really good framework, but we need to still remain, as I said, agile to the management of risk and opportunities. In terms of some of the detail, the paper does cover both the All Wales Capital Programme and the discretionary. What I really want and sort of support for today is what's in the discretionary, but I do just want, and I'll just talk a bit first though about the All Wales Capital Programme. The paper sets out on page 3 of the report, I'm not sure where it is in abundance, sorry, just reminds us of what our current allocation is for the All Wales Capital Programme. So that's set out in the table. It's just over 42 million, a little bit higher because we've had some additional money around the radiotherapy unit to support the removal of RAF. So, but to all intents and purposes, that's the approved allocation for next year. And then there is a bit of detail, just an update on where we are on some of those projects, which I wasn't going to go into in detail, but they're just there for completeness. The paper then also sets out what our current pipeline, sort of live active work, some of which we've touched on today, but in terms of where we are expecting, even before the end of this year in some cases, to put in requests against the All Wales Capital Programme. They're not yet approved. So you'll see those under the heading of pipeline projects without approved funding yet. So there's a lot of activity within project structures to finalise and scope those out. I think the most important thing under the All Wales Capital to note, though, is that back in, I think it was just in December, Welsh Government triggered a prioritisation exercise for All Wales Capital. So everything that's not approved, they have initiated a methodology that is currently out with all health boards for us to assess priorities against certain criteria. The detail of that is coming to the planning committee at the end of this month. We can see the criteria. So we are currently working through that methodology. So in terms of our pipeline, that will emerge and be reprioritised on the basis of that. Again, just important points to note on that exercise. It doesn't include the regional partnership money. So the IRCF as referred to often, so the work we do through the regional, so the wellbeing hubs that are funded through there, the work we do with housing associations. So that won't pick up the prioritisation, but it isn't within scope. And also there's some national informatics money that is also not within scope. But it is going to be, it's a really laborious process, detailed templates for each thing on our pipeline. And it is going to be quite interesting, I think, for us, but also for Welsh Government on how they comparatively compare things where some things, even though they may not be approved, they're very well worked up because they've got draft business cases, and some where we're still doing the work. So I'd give an example of us, our solution around RAC in Neville Hall. We don't have all the detail worked up yet, but I would anticipate it'll be a priority for us because of all the risks. So it's going to be really interesting, the relative prioritisation, where in some areas we have a lot of detail. That was all I was going to say on the All Wales, and there is a section on EFAB. Just come into the discretionary programme there. I'm pleased to say that since the paper was published, we've had confirmation of our discretionary allocation, and it has fortunately gone back up to the 2.8, just over 2.8 million that we had pre-COVID. So that is really positive in a time of reduced resources. We're really grateful that allocation has gone back up. We will see from the section on discretionary that some of that allocation is already allocated, either in terms of our matching of our EFAB, so our money we get from Welsh Government to support decarbonisation, health and safety, fire, etc. And some of it is obviously schemes that we've already committed. So the detail then, and in terms of getting some approval today, is against the remaining 9.8 million when you take out those allocations. So I'm looking at the table that's called 2024-25 discretionary capital plan. So it's the proposed deployment of the 9.859 million. I'll call out a few bits within that, and then I'll pause because I'm sure there are lots of questions. We typically give some statutory allocations to colleagues in health and safety and Jamie and facilities to deal with statutory compliance, and we've increased that this year based on the knowledge we get from money around backlog maintenance and the risks we know we have around backlog maintenance, and the internal audit report that will be coming to audit committees, the recognition of the real challenges and risks we've got there, which we all live and breathe as we look around the room, increasing that. And then we've worked really closely with the divisions and corporate areas on prioritising the use of the discretionary, using criteria around it. It is predominantly around the management of risk, whether that be service or infrastructure, but also opportunities to improve efficiency, and then where possible if it's service developments. But for obvious reasons, the priority for discretionary often goes to management of risk and improving outcomes. So the table there does summarise what the allocations by division and corporate area are, with some examples of how things that we've been seeking to fund for a long time, we are able to fund. It seems a pharmacy robot is a bit of a big one. Yeah. And then there's also an allocation at the moment, a provision of some work we'll need to do in the context of preparing for All Wales money, whether that be fees to support certain developments. So we do allow a provision for that, but recognising that will be fluid in terms of one, the opportunity to get back when bids get back into the programme when bids are approved, or challenge or challenge them completely, and they may not even materialise. But we always have to allow a provision for that, otherwise we'll be caught short. Final few things just to draw out then is we talked in this later on the agenda about health and safety risks. It does look quite stark when you look at that, health and safety 0. Just to reassure colleagues, there's health and safety allowance within the EFAB monies. There's health and safety within the statutory allocation, and we are working with Peter and his team to review the replacement and the improved plan, so we can expect more to come into the position around health and safety. I also wanted to note we talk about mental health and those risks a lot. If you look at the partnership allocation and again the EFAB allocation, a lot of that is going towards mental health as well. The current position is there's a contingency of 1.5. We do expect that to change as some of the clarity emerges, and there are also a couple of areas that are over 500k that we just need to draw to the board's attention in terms of anticipation of additional required because of the quantum there, so they're outlined in that section as well. I appreciate it's really meaty and long report with lots of detail. I hope that's been helpful just to give a bit of an overview, but as I said, I think the main area, recognising that prioritisation exercise, is just to get seek some support for the proposed opening position for discretionary. Thanks.
Thank you, Hannah. Pippa?
Thank you. And yes, meaty report, but a lot in it of which is really interesting. Plainly, I was impressed by the fact that it's based on risk, you know, but obviously we've got challenges with RAC, for example, and I looked at this and I thought, right, there's some really good health and safety stuff around fire in Neville Hall, and then I thought, are we likely to pay for something that then we're going to change quite quickly afterwards? And I just couldn't get a sense from this of whether there was anything where we would be investing some money into something for a very short period of time just to tide us over until something else happens. And I couldn't get that paper, so I just wanted to ask the question.
Yeah, I think that's a really, really good question. The reality is the stuff that you're right, it is prioritised on the basis of risk, and particularly some of those fire areas. Some of them will be in the H block building, but even if there's a requirement to spend some, what we want to do is avoid abortive costs. I think that's hopefully it goes without saying. But I think we need, the reality is if we cannot remove that from areas in and we have to make it safe for them and incur costs to do that, like we have with the actions we've taken against RAC. But the approach to this and the link with Neville Hall is that if we can re-provide them and move them into an area to avoid abortive costs, we will. But where we can't, recognising that if we're talking about a new build, or it's going to take a while, so we need to manage the risks in the meantime. I can't, and I'm happy to pick up in terms of, so what is that quantum? But we do lots of joint working between the fire team, Peter's team, and the estates team to avoid any abortive costs that we would otherwise incur. Thank you.
Are there any you want?
Yeah, I guess just building on what people have said there, I've got a couple of points actually. One is that ties into an estate strategy. Second one, obviously the health and safety you mentioned already, and that does, you know, on the face of it, it looks scary, but I appreciate there are bits in it. But given where we are with the health and safety review that's ongoing and where we are with our fire assessments, and there's a comment in there that says there are insufficient funds from a capital point of view going into it, that raises a little bit of concern. So we need to be ready for some of the risks that are coming out of that particular review.
Yeah, so just on that, so we called it out in the report that while some of the review and the work on the, whether it be fire replacement programme or the other health and safety, so the capital team working closely with Scott. So my anticipation, that was my point about us having to be a bit agile, is that more will come in from a health and safety perspective to help us manage the risks as the clarity emerges there.
Yeah, I'd be amazed if anything did come up, given where we are with some of those reviews. Third one is obviously we've got all this capital plan and we're being asked to make a decision knowing what the revenue impact is. of any of these? Now, some of them obviously may, be positive in terms of revenue.
So from a discretionary perspective, which is the decision today, all Wales Capital, each of those, as you know, has to stand alone on a business case anyway, where all the revenue things are worked through and implications. From a discretionary perspective, just to give assurance that to get onto this to get onto the list, the programme, there is, I'm sure colleagues will agree, there's quite a detailed process and pro forma to go through. And it basically, if there's a revenue tail, big red flag goes up, and there's a conversation about how that is mitigated, avoided, and resourced. And because they're risk management, there's hardly any that will have a revenue tail. So agreeing to this doesn't sign us up to any additional revenue costs. So that needs to be really clear. And what we do try and do is use this, as we said already, manage the risks, but where there is opportunity to use the capital to reduce revenue. There's a couple of examples in there. Some of the examples, there's investment in tiny equipment costs. So it's how we use it in that way as well. So the current discretionary plan doesn't increase revenue costs.
And the new building for at the Grange, I think for the Welsh Government on, be added to this then, or?
So that is in our All Wales capital. So the ED, that's down there. I think they call it GUHED extension. So that's under the All Wales.
Okay, yeah, I've got it. Sorry.
Yeah,
but that will have a revenue tail.
Yeah, so that's in the All Wales bit. Where, as I said, they each have to have a business case.
Getting funding for that, or is that?
Won't get funding for the revenue.
So that'll be additions.
We've just agreed that.
Yeah.
Yeah.
Checking that, but it's the funding side of it.
Yeah.
We've got that piece, but.
And I think we did else. Yeah, we did. I think we've picked up as well, haven't we, in the Finance and Defence Committee, the capital investment, not exclusively, but particularly those in the All Wales programme, how we get a bit more disciplined in bringing back the benefits back through to the F&P committee. So one being, we've just opened endoscopy, breast will go live soon. Those were business cases, realisation of benefits. So bring a programme of those valuations, post-project valuations and benefits realisation.
Okay. Any further questions? David?
Not so much a question, but a comment. I wanted to highlight. Obviously, this applies not just to the area I'm going to bring up, but to others. I'm going to bring it up because it's my area of expertise in terms of digital and technology. There's quite a few items in the informatics budget that have not been approved in this, and that we're going to have to accept the risk on. That may increase our risk of significant impacts because of cybersecurity or others. In particular, for example, one of the pieces that isn't approved in this is updates to our backup and our security platforms. That may have a significant impact on us, and we just need to be aware of that. We need to be cautious around the potential impacts there. But also a lot of this discretionary capital funding, whether that's informatics or for fire and health and safety, it's all about trying to keep the lights on our services currently, and does not help us transform our services or change our services. Obviously, I mean that's fairly obvious from this, but in a digital world, the discretion, the capital very significant changes that we are expecting or hoping in the transform of our services is not there, and we're gonna struggle, particularly given the national funding for digital has also been substantially reduced next year. So it's going to be increasingly difficult for us to change our services and transform our services, and to make those radical changes that we are needing to make our financial position, given the funding available.
Yeah, that's a really good point, and it's a reality. I've tested this with colleagues across Wales and also been involved in health boards as well. I don't know if I'd go as far to say that's the purpose of discretion, is to help keep the lights on, but it is there to help manage those risks. But you're right, where then do we go for the transformative, and how do we make sure we don't do things that are abortive? A conversation earlier. In terms of digital specifically, We touched on, you know, a benefit of having done this. We keep doing this early is to try and make maximum opportunity of end of year bunnies. We have been invited, no guarantees, to put in digital and some infrastructure end of year. If we are successful, that will release money back into this capital programme to put at the digital priorities as you rightly identified. So we don't know when we're going to hear if we've been able to, but we took a sort of a march on what's here in the digital space already to try to free up some money for next year to go against them.
I think it's just worth adding that and it is recognised in terms of the Chief Digital Officer for NHS Wales has pulled this out a couple of times, but Wales is significantly underfunding digital and technology compared to every other health system in the world. We are expected to do digital and technology and transformation on a shoestring. We have something like a tenth of the funding that Scotland gets for digital and technology. We have that's less than England gets, for example. And so our ability to actually transform our services is incredibly limited. What I'd like to, part of the reason why I'm bringing this up is I'd like to just draw the line between the minister's statement in the Senate yesterday about our ability to develop plans to fix our financial issues and the lack of capital and support we get from Welsh Government to actually do that. It's all well and good standing up and telling us that we're not doing enough, but Welsh Government is not doing enough to fund digital and technology and the transformational efforts.
Thank you, David. It's helpful. Any further comments? We accept this as it stands. Thank you. Can we have a 10-minute break? To 3.6 risk management framework, please.
Yeah, thanks, Chair. So this paper presents the board for approval an updated risk management framework, and it is supported by a new risk management policy and board's risk appetite statement. The updated framework builds on the board's previous strategy approved in September 2021 and sets the context for us in further developing and embedding our risk management system within the organisation. And it also takes into account internal audit recommendations made for improvement. Some of the areas strengthened within the framework include greater clarity on responsibilities and accountabilities, the process for capturing and recording of risks, and we've provided clearer focus on the escalation process and the threshold associated with it. The framework is supported by a risk appetite statement, and this represents the discussions that the board has had during its development sessions to consider the risk themes and boundaries for inclusion within this. We've also developed a supporting risk management policy to support the operationalisation of the framework, to support that embedding at the levels of the organisation. Members of the Audit Risk and Performance Committee have been provided the opportunity to comment, and where feedback has been received, that has been factored into the final draft versions presented here for board approval.
Thank you, Rani, and thank you for the work that's been undertaken on this. Has anybody any queries or questions? Good.
Yeah, firstly, I think these are really good documents. I think in terms of these, strong set of documents that will carry us forward. One, and thank you for the opportunity to input into them. We've had a number of discussions, etc. There's one piece in there I still feel a little bit nervous about, I guess, and that's within our risk capital statement document. I think it is around the level of our appetite for the section on confidence and trust. And specifically, I think around the piece that makes me nervous is around the use of the word reputation. I'm nervous on that front simply because when you look at the appetite that we have for a reputation, well, it's effectively a reputational risk. Does that outweigh some of the other risks that we're looking at? And coming from the industry I come from, the number of people I've heard say, oh, I was only doing it to protect our reputation and that kind of thing. I think our reputation should be based on us doing the right thing for us, population, etc., rather than protect our what people may perceive as our reputation. So I'm still nervous about having that in there at that level.
Right. Natalie?
But so we have had an initial discussion. So I think when we discussed this as a board in the development session, where we agreed these themes and the level of risk the board was willing to consider to take in these themes. Cautious was where agreement was reached. I guess I was just talking about the MIU example. So when we extended our programme of work, I think that demonstrates our appetite to reduce the level of risk to damaging reputation. So I guess it's just about being representative of the approach we actually take in our working with public, our patients, stakeholders and partners. So I guess you and I don't.
Yeah, I'd say it's probably that word reputation more than anything else that I'm nervous about. And as I say, the number of times I've heard I was only protecting a reputation. The wrong thing, if you like. It's just making sure we do the right thing.
And I wonder whether we define what we mean by reputation a bit better, because I think you're right. You don't want to do things just reputation. It's the wrong thing to do. But I think what we do recognise the importance of the reputation of the health board in terms of public confidence, staff belonging, staff kind of association.
Doing the right thing.
I think it's, you know, and making sure we are, like you say, it is about doing the right thing.
And it's probably a different definition of what reputation is for our customers. And like it as our customer, they'll have a different view. You know, whatever we do with those minor injuries, everybody think, oh, they're closing it down. We'll always have I can't say it'll probably have a good impact on our reputation of reducing those from our customers, but from us, from our point of view, it's the right thing to do.
Yeah.
So as I say, it's probably that word reputation.
Yeah. I think we could more carefully define what we're talking about. Yeah. So that we're clarity, because we all agree it's not just oh my goodness, you nasty people. It's you've got to.
And you know, it's and people from trying to do the right thing could be doing the wrong thing. It's know, are they hiding something? Or withholding something because it might damage our reputation.
Yes, we
still have to have that openness.
Thank you.
So if we come to confidence and trust and the cautious level. If we bring back reword into the next audit committee.
It's something around doing the right thing.
And reinforcing that reputation will never trump integrity.
No, quite.
Governance
and all the rest of it.
I think
because that's what our reputation should
absolutely be based on.
That's where the trust thing comes from. That's probably that's I say.
I think it's just reinforcing that maybe. Without changing.
So I'll reword the description and bring that back to the next meeting.
Peter?
I just want to say this work is really important, supporting the challenges we've got in health and safety as well. And one of the things that one of the risks we've identified in health and safety is around the quality of risk assessments. This work to improve that capacity within the organisation to undertake really good quality risk assessment is really important. It will naturally then benefit health and safety risk assessment. So, I really support it from that perspective.
Thank you. Are there further comments or questions? So we're happy to do that and bring back the definition of reputation to audit.
Yeah.
Thank you. Thank you for the hard work on this. I know you worked really, really hard to get this right. And thank you. 3.7 All Wales IPFR policy.
I'll present this, but I'm going to ask James for support on any detail, if that's okay. So this is a policy that's been considered through our WISC Joint Committee and has been asked to be recommended to boards for approval. The policy has been updated to reflect learning from a judicial review, and it was identified that the policy was being interpreted in a way that was contrary to its original intention. So WISC have worked with legal teams to update the policy to strengthen it, and is therefore recommended by WISC to board for approval.
Who chairs the IPFR policy board now?
So it's chaired by JD Gibson on your behalf, and it's led very heavily from a sort of technical managerial point of view by Aneurin Bevan, who's also the lead for managers in Wales who manage IPFR.
Good. Oh, that's sound. Any comments or questions, Helen?
That's right. I just wondered how many IPFR requests do we get in Aneurin Bevan each year? Just to see what the size of the issue is, really.
It's a probably should receive even more than we do, and it's something that is likely to go up as we improve things like our medicines management policy, for instance. So there are a number of drugs which, because of AWTTC guidance, we don't use to the full range of the license for the drug because of health economic analyses. But I think the IPFR process in Wales is really good because it does mean that the patient needs the treatment. The equivalent process in England has a capped budget, which means that once the pool of money is gone, the individual patient can't get the treatment. Whereas in Wales, we have an evidence-based approach to decide the clinical benefit of the intervention or the drug being suggested. And if a group of clinicians on reviewing the evidence agree the patient benefit, I do. So to give you an idea of the size of the budget, it's about 800,000 a year. So, you know, it's not inconsiderable. And the sorts of things that we pay for in IPFRs are specialist opinions not available in Wales, treatments not available in Wales, and extending the licence.
So we therefore have many appeals.
Sorry?
Do you often have an appeal from the decision of your IPF?
We've had one appeal in the time I've been here, which we were able to resolve.
It would be helpful if we could have a very short report on the scale of the issue.
So absolutely. Would you mind if we deferred that, because we're doing perhaps not to the next board but to the board after, because we're doing a really detailed bit of scoping work at North Wales level about the opportunities for savings available by looking at INUs together with IPFR. So you know, I feel I wouldn't be able to give you the full picture.
No, that'd be helpful. Okay. Okay, so that's approved. Thank you. 4.1, the external audits report. Can I welcome Andrew Dowden and Nathan Couch? And Nathan, this is your last meeting with us. You horror for abandoning us like this. Thank you very much for your helpful support and as a critical friend. Thank you, really. You've been really good. Thank you. Andrew?
Thank you, Chair. So today we've got the annual audit report and structured assessment on the agenda. I'll be covering the annual audit report, and Nathan will talk a little bit around the findings from the structured assessment review. The annual audit report provides a summary of work completed in the 2023 calendar year. It summarises reports which we have already passed through clearance and through committee. The audit of accounts work concluded the Health Board's accounts were properly prepared and materially accurate. We issued an unqualified opinion on the true and fair view. So unqualified, you probably all know this, but that's good. In terms of then the regularity opinion, we did qualify that, and that's on the basis that the Health Board didn't manage to spend within the expenditure between 2020 and 2023. The report also includes a summary of key messages from our performance audit work, and that includes the review of orthopaedic services, the structured assessment, which Nathan will be talking about shortly, the National Workforce Data Briefing, which has some quite interesting messages. It is pitched at a national level, but it's got some interesting messages around some of the trends in terms of workforce over the last 5 to 10 years. The annual audit report also includes a summary of the workforce planning review and review of primary care services. Those two reviews will be going through the audit in February. And then finally, the appendices contain some additional information relating to the timing of our work, our fee, and an overview of the financial audit risks. So that's really the basis of the annual audit report. What I wanted to do was just also say thank you very much for the support over the last year, particularly. We recognise there's been some significant challenges at the Health Board, and that everyone we speak to is incredibly busy. So we really appreciate the level of engagement.
Thank you, Andrew. That's very helpful. So no areas where you think we're messing up badly?
Not necessarily messing up, but you've got some significant challenges as an organisation.
Yeah. We have. Thank you. Any questions to Andrew? No? Thank you for your diligence. Very helpful to us.
Thank you, Chair.
this feels like quite a new experience for me now, being back in person in the room. So our annual structure assessment work, many of you are familiar with what that entails, but for those who don't, it examines the health board's corporate arrangements relating to governance, systems of assurance, planning and financial management. This year we streamlined the approach slightly in that we didn't cover the use of resources as part of the review, which traditionally focuses on areas such as workforce, digital and estates. The approach going forward would be to cover those areas alongside other aspects of the health board's arrangements as part of separate, more in-depth reviews throughout the year. This report has been taken through the usual clearance process, and health board colleagues were given the opportunity to comment on its factual accuracy, tone and balance. And we've also taken the report through the Audit, Risk and Assurance Committee at its November meeting for scrutiny. Overall, I think the findings demonstrate that while the health board is facing some significant challenges, it is making good progress in developing and its corporate arrangements, which will provide a platform to tackle those challenges over the next year. That said, it wouldn't be an audit without some areas of improvements. We made a number of recommendations to enhance the arrangements further, or to ensure that the health board finalise and embed work that was in development at the time of the review. I'm conscious of time, so I'll quickly take you through our key conclusions for each of the areas we've reviewed. So overall, we found that given its financial and performance challenges, the health board needs a clear plan to set out how to achieve financially sustainable service models. In general, board and committee governance arrangements and the corporate arrangements for development plans are reasonably effective. However, there is scope to provide clarity on both the impacts of actions set out in plans and actions taken to improve performance. So that's the overall conclusion. And underpinning that, then we found that board and committee arrangements are reasonably effective. But there are opportunities to improve the quality and timeliness of information to ensure effective oversight of the key challenges. We found that the health board is making good progress in developing and refining its systems of assurance. However, it will need to effectively embed new arrangements across the organisations to manage the financial performance and quality risks it faces. In terms of planning, we found that the health board is developing a new long-term strategy which provides an opportunity to plan more sustainable services. There are reasonably effective arrangements for developing corporate plans. However, progress reports do not provide enough detail to demonstrate delivery is on track. And then finally, the health board is facing significant financial challenges. Whilst there are reasonably effective financial planning and financial management arrangements, the health board needs to establish control over savings delivery to prevent the financial position from deteriorating. As I mentioned, we did identify 7 recommendations, all of which were agreed by management with appropriate actions and implementation dates. And just finally, I'd just like to pass on my thanks to Rani, the corporate governance team and the wider health board colleagues for their continuing support with the review. Thanks very much and happy to take any questions.
Thank you, Nathan. Are there any questions? You want to add anything?
Not really. We had a good chat through these at the audit committee. We've obviously had a chat with the guys outside of that as well. It is what it is, I guess, in terms of a financial position. As Nathan said, it's we have challenges ahead. But through management responsibility, etc., we're on our way to getting things in place to meet these challenges.
Thank you. I just want to kind of thank Nathan again for his work. I think it's a fair, constructive report, and I think we recognise the issues, the progress we've made and the areas that we need to continue to focus on. So I'm comfortable they are areas that are priorities for us.
I think I was just going to say something very similar to Nicola, actually. I think the narrative in this is particularly helpful, and it's, it gives us an opportunity, doesn't it, to shine a light. I think a lot of stuff we're already aware of and working towards, but I think it's really helpful to have it presented in this way. And I also wanted to thank you for the work that you've done over the last period. Thanks.
Thank you.
Just a personal thank you from me, really, at the end, for So Nathan, we've had a fairly constructive, it's been a pretty constructive relationship over the time. So.
Thank you. Thank you. So obviously we'll be tracking progress on all the recommendations.
We've got a tracking system.
We have indeed.
So all of those will come to audit.
Exactly. So it'd be helpful if contained within your audit committee chair's report, you could just do a very brief overview of how well or otherwise the tracking system is making, or the things in the tracking progress.
Yeah, we can include a small statistic every month in terms of all of the action items that we've got. Yeah.
There's a small section in the report that comes out, but we can make that more detailed in terms of the volume and where there are key areas.
Because we all appreciate that this is an incredibly difficult and different situation for this health board to be in, and we need to make rapid progress. Otherwise, we'll have teams of goodness knows coming down on our necks. Thank you very much. Financial management, or another jolly subject.
Thanks, Anne. So we've got in the papers today the month-line financial position review 23-24, which is the period ending 31st of December 23. In terms of the KPI box early in the report, just to draw out some of the key points. So the year-to-date revenue deficit, £47 million being reported. That's aligned to our mid-year forecast. The forecast has improved by 1.2 million, and we've posted 56 million deficit with Welsh Government out of month 9. I will say at the time of writing that is prior to any estimates of the strike action having an impact on our revenue costs. In terms of capital forecast, we're online to balance on that and achieve our spend as per plan. The 67% spent in year, which is quite a healthy percentage because generally, historically, a lot of capital spend across Wales tends to be back-ended. So we are managing that throughout the year, so that's good. And in terms of our public sector payment policy, we're achieving over the 95% target and 97%, or paying creditors within 30 days. Our underlying deficit has been held at £81 million, and that will be refreshed as we work through and finalise the MTP process. In terms of key points to note, the revenue forecast 56.4 million does include the adjustment from our mid-year review position to include the WAG funding we received, support funding. There are conditions around that. I'll come back in a moment. And the benefit or the improvement on the forecast has been achieved through a reduction in the prescribing forecast costs, largely due to pricing changes, which I'll elaborate on in a moment. As I say, the forecast is before the strike action impact and does assume, as advised by Welsh Government, get full funding for pay arrears. In terms of the Welsh Government funding, we have been allocated a control total revenue deficit of £13 million. So basically, Welsh Government have given us permission to overspend by £13 million. And we've also been given that support funding of 65 million, which is conditional on making progress towards our control total. For 23-24, there hasn't been any further clarity on what making progress means. But on the basis we've moved by just over £1 million in our forecast currently, that's making progress in my mind, but I'm sure Welsh Government would like to see it further, as would we. So that is important in terms of being aware of that condition. A risk range for revenues from 51 to 61, and that's linked to some of the anticipated income we're expecting to receive and the potential for variability on our cost growth forecast, particularly CHC prescribing and where our operational pressures driving workforce requirements. In terms of strategic cash, so you may remember that we have put a formal request into Welsh Government for additional cash cover to deal with our deficit. we've been advised that before the end of January, we will be informed of what Welsh Government can support. Depending on what that figure is for us, we broadly put a figure in that's equivalent to our deficit. We may have to take some action in terms of paying creditors and looking at how we manage that. Obviously, the closer we get to the year end, the bigger risk around that cash deficit emerging. So watch this space. I have a degree of confidence that we will be supported financially with cash for a strategic element, but obviously that's not certain yet. In terms of some of the cost drivers, so our pay spend reduced by £1.2 million in month 9, significantly across our variable pay. So our variable pay at the moment for December was 6.8 million. And that's below our reduced run rate that we've seen throughout the year compared to 22-23. So that's, again, a very positive move. We do know that because of the Christmas break, a lot of staff, substantive staff, were scheduled in as part of the plan. So we may see a little bit of a bounce when we do January's figures. But I say for December, that's a very, very positive move. In terms of non-pay, we've seen a reduction, but most of that reduction of 1.8 million is due to not having some high costs go through, most of which were supported with funding, but on a spend basis, that is a reduction in month 9. In terms of operational factors, so our delayed transfers of care at a point in time for reporting of 287 is still significantly higher than pre-COVID levels. That's a mix of health, social care and other factors. So that's all identified in the report. The key message being that we need to do more to get those numbers down and aid flow and operational pressures. In terms of prescribing, so the reason why we were able and we had a degree of confidence to reduce our forecast on prescribing costs is because we had a price reduction of 7 pence per item, which doesn't sound much, but we issue millions of items. So that was driven by category M, which is more, I describe that as the generic drugs. It's not purely generic drugs, but the non-patented generic drugs cost reducing, and a particular drug called apixaban that has gone from £50 to a £5 price. So that's a significant issue for us. So we've taken the position that we think that's going to hold till the end of the year. That's obviously kept up to date and monitored every month as information comes through. CHC placements for mental health, we are covering 414 patients. That's a reduction of 5, and adult complex care 556 patients. That's a reduction of 8. And in terms of activity, the graphs in the paper show that we're broadly online year to date with the numbers in the plan that we intend to deliver. Again, that's prior to any strike implications. Nicola identified earlier that we are now moving to a targeted intervention, so we'll have to understand what that means from a financial perspective for us. In terms of savings, we're holding our forecast savings delivery at 42.5 million. Against our 51.5 million target. Across Wales, that's the highest figure for any organisation in terms of targets or delivery against targets. So that's a good place to be. Obviously, we need to go further to achieve longer-term financial balance and try and improve where we are this year. Year to date, 27.9 million have been achieved. Obviously, we've got now the last quarter to really ramp up. Of those savings levels, 42.5, 40.5 million are coded as green, which are either achieved or expected to achieve with minimal risk. £1.9 million is amber. So again, we're de-risking the plan in terms of our savings. And also in terms of those savings, where they are recurrent, the full year impact for next year is estimated to be £32 million. So again, that's a good proportion of the savings being recurrent. So again, a positive place to be. So to conclude, the monitoring returns information we provide to Welsh Government are included in the papers as we requested to do, which effectively reflect our board report and the contents of this briefing. So hopefully that's okay, Anne.
Thank you very much. Thank you, Rob. Are there any questions for Rob? I think we have to acknowledge the progress that is being made, particularly on savings. It's a better overview than we've had in the past, but nevertheless, the serious mountain that we have to climb. Shelley?
There was a couple of specific questions. The strategic cash support, Rob, if obviously I know you say you're fairly optimistic that we'll get what we've requested. If we either don't get anything or we don't get as much as you've requested, you know, what's plan B? So how will you go about, I don't know if the word balancing the books, I'm not quite sure what the terminology, so that was the one question. The other thing was that there's an increase of 10 paediatric CHC placements, which seemed quite a lot in December, and I think it's 62 was the number overall. And I just wondered, presumably those patients have to go out of county because we don't have the facilities or the expertise or whatever to deal with those. And I wonder what the plans long term are about whether or not we can bring more of those back into the county. And the other one was just Jenny, probably, of the 287 fit for discharge, which is in the report, and I appreciate that might have changed, and you've got your patient safety teams. I wondered, it may have been to patient safety, and I apologise, but I just wondered how we're evaluating the positive outcomes from those meetings, because I know you said they are working, but obviously the numbers are still quite high. So I just wondered what are the metrics for evaluating how those teams operate. And I suppose my other question would be, at the moment, the way it sounds to me is you have specialist teams who are perhaps bringing people together, and as you mentioned earlier, I think have a wider view of what's in the secondary sector, what's in the community sector, etc., in terms of what's available. And at what point would there be an exit plan so that that particular work that the team is specifically doing now would be, if you like, transferred to the people in the substantive roles within the, I'm saying secondary sector, but wherever those patients are. Does that make sense, what I've said? That those are the three areas I wanted to ask about.
Thank you.
So if I pick up the first one, I'll ask Jenny to pick up the last one. So in terms of strategic cash, if we don't get the level of funding support we need, we'll need to look at what people owe us and what we owe other people. So in terms of maximising our debtors and income, making sure we receive funding, we don't generate an awful lot of income beyond the public sector. So there is most of it is covered through a cycle of receipts anyway, but we could look at that. We have done some work to look at what it would mean to slow down certain pay runs to suppliers. Obviously, that would jeopardise our public sector payment performance, but I would suggest not going bust on the cash is probably more relevant to us as an organisation. In terms of the estimates, we've looked at that. If we just look at our suppliers, that won't give us enough cash cover for £56 million. And obviously, as I said earlier, time's running out to take that action because the systems run quite early in terms of payment arrangements. We think that the supplier option may give us 10 to 15 million, depending on payment cycles between now and year end. That's our sort of expected level of payments out. Now, that's the private suppliers. We also pay significant values out to other NHS bodies, and we could choose not to put those payments through. Now, the reality of that, sorry, I haven't got the monthly figure in front of me, but it's going to be of the order of about £20 million. The issue with that is we pay those on the first day of the month. So next week, I think next week is the first day of the month, maybe the week after. So Welsh Government really do need to provide us with a position as soon as possible. Now, if we look at not paying our NHS providers, That will potentially get us there, but it will cause chaos across NHS Wales. So in fairness to Welsh Government, yes, we're in deficit and we shouldn't be, as are other organisations. So it's not just us that have this issue. So that's exacerbating the position across Welsh Government. So yeah, in reality, I think a solution will be found. Welsh Government aren't initially indicated that it was up to us to manage. I think I reported that at the last board briefing. That has been further clarified through discussions with chief executives and at last week's meeting of all finance directors across Wales. It sounded positive that the solution would be found. There's a bit more work to be done at Welsh Government outside of the NHS element, just to see how that cash can be pulled together. So we do have actions we can take. Those actions, to allow us to balance, will cause, as I say, chaos across NHS Wales. So hence my degree of confidence, but I'm not saying this is certainty yet because we don't know that. In terms of paediatric placement, so paediatric placements profile, given the number of placements we have, I'm not sure if it's a peak or not. It may be during December. We can look into that. But the reasons for them being placed outside are usually because they are specialist in nature. We may have some capacity internally, but it depends on the nature of that care requirement. And children's placements are very, very specialised generally, and they are spread throughout the country, and the UK, I mean by the country. And it is an area that is constantly under pressure. So if you need more than that, I can find out more than that.
No.
But that's a
No,
general.
that's fine. Yeah. Thank you.
Jenny.
So Shelley, it's complex. So I've just got the data up. So once a month, we validate our data with the local authorities on delays in the system. And there are a number of reasons that make up those delays, with the predominant ones being access to reablement. In fact, social work assessment isn't necessarily waiting social work assessment isn't one of the higher categories, waiting for packages of care, housing, waiting for an appropriate care home. So we know there are a number of very complex reasons, and we need to do some further work on our data. But we have seen an improvement in discharge numbers. So for December, we saw a reduction of 40. And whilst that's only 40 on 200 odd, that is still a move in the right direction. And some of this is deeply cultural. And, Anna's already asked me to bring an update back to the board, because we have a programme of work that sits in 6 goals that covers discharge. I'm the exec lead. Linda Alexander is the current SRO. That has a number of work streams, which we have put into place, I would say, with rapid succession over the winter period. So I don't think we've done the number of initiatives that we have in such a short period of time. And actually, not sure anyone in Wales is. We've got full engagement with local authorities, so they are very embedded in patient safety events. And Linda and I often meet with them to discuss some of the difficulties. One of the things we found is that we need to do work with our wards, in particular around, I think, some of the non-medical ownership in terms of patients and discharge. And I will, Peter will know, there is a strong therapy and nursing leadership thread that's going to be really, really important as we move forward. We're reviewing our transfer discharge lounge offer, because we know if we move patients early in the morning, that helps the system. We've got Ready to Go coming online. We're reviewing the way we manage step downs. So we found, for example, that too many patients being put on the step down list when actually they should probably go home. So there's an education and training piece as well within this. So I'd say it's complex. I think we've got more engagement from our local authority partners than we've had previously. I think they're very embedded in the patient safety events. And I think this is all about empowerment and leadership, because that is what is going to make a difference. But that's not to the exclusion of our medical and therapy colleagues, because we are an MDT and we focus on being around the patient and making sure that they get to the right environment first time. And as I said earlier, sometimes it's very difficult if you're an acute therapist or nurse or doctor and you've never worked in the community. You don't understand the level of risk that can be taken in someone's own home. And actually, if they're confused, they're probably better at home because they'll know their environment, they'll know their way around it. We put them in unfamiliar environments and wonder why they fall. So I think this is all about doing the right thing for the patient. And I think sometimes there is the other element that I think that Kelly is looking at as part of, Kelly is the SRO for frailty, is looking at in goal 1, is really how we engage with our care homes, because again, we're seeing too many patients being admitted, probably at the wrong point in their treatment pathway, their disease pathway. And that's about giving them confidence to not admit, but also what's the support that we then offer into those care homes. So goal 1 is very strongly linked to goal 5 and 6. And we keep a track on that through our safety flow meetings every week, but the formal programme management is very firmly through 6 goals. And I think sometimes people look at care home bed availability numbers and think, well, we're not using our capacity, but it has to be the right bed for the right patient. And sometimes that's not always the case. So I think, it's a multitude of factors, but actually we've pulled together, I think, a very robust programme of work that will enable us to move forward, I think, at a rapid pace ready ahead of next winter. But I'm very happy to report back next time, Jen.
Lovely. Thank you, Jenny. That was really very helpful. Anything further, Shelley?
No, thank you. That's great. Thanks, Jenny.
Thank you. Are there any further questions? Could I just, Rob, then come back to this, the statement that you made about conditionality in the allocation? What exactly, has there been clarity, because I've not seen it yet, about what conditionality means? And what are the consequences of not meeting the control target?
So in terms of, I'm going to quote you what's in the allocation letter for conditions. So in terms of the conditional recurrent funding for 23-24 underlying deficit and the inflation increase, which is over 4.5 million. What it says is that it's been built into the recurrent allocations for 24-25. It must be noted, however, these allocations are recurrent in principle and conditional on progress in delivering the target control totals set out by organisations. So that's what that says. That is aligned to the previous letter we've had for 23-24. In terms of an informal update, there has been comments alluding to health boards in the new year being able to maintain control totals on a recurrent basis, qualified for this funding. That hasn't been formalised, hasn't been made explicit. So I think we deal with what is explicit in notification to us as a health board, but just to be aware of those conversations or views being expressed. In terms of not achieving our control total of 23-24, I guess the escalation in terms of our intervention, our escalated status to targeted intervention is part of that. I think it is very explicitly part of that. In terms of financially for us, it will obviously be whatever our deficit reported will exacerbate our statutory duty to balance on a rolling 3-year basis. And obviously our outturn last year of 37 million is a challenge to do that anyway. So in terms of what it means as an organisation, I think I would just reflect it's the debate we've been having around we need to develop a medium-term plan to recover as we intended to this year over ideally a 3-year window. That was before, funny enough, before the significant uplift of funding from Welsh Government. There is an issue, I think, which is So I'll come on to this in a moment. So for 23-24, I think the biggest issue for us is understanding what this targeted intervention means.
Yes.
There is a description of providing us support. Not really sure what that means. There is a challenge, I think, on us as an organisation to create our own plan and get a grip in terms of what that's going to be, which we've touched on before, and that will hopefully emerge as part of the NTP process now. Challenge to do it in 1 year. I don't have a degree of confidence on that, but we do need to look at how we plan that out over the next couple of years, I would suggest. So the ultimate, I think, as far as I can see in terms of line of sight, is I'm hoping we'll have another clean audit opinion on our accounts, but in terms of the financial position, we will have broken our regulatory duty, so there'll be an opinion. I think that's how it's going to land in terms of visibility. The intervention, the implications of that, I'm not clear on. Yes, we'll be probably required to produce more information, more analysis, and more meetings. But in terms of what that gives us more than we're already doing, I'm not sure, because we do have a lot of work in progress. I think the challenge for us is to convert our work in progress to actual plans as soon as we possibly can. So that's where I think 23-24 gets us. In terms of this funding not being received next year, one of my concerns is until we get absolute clarity, it may mean that we will be considering decisions to save an extra £65 million that could affect patient services. So there is something around Welsh Government being very plain around what they mean by making progress, and what time frame are they looking at, and what that means for us individually as AB. I'm coming on to the allocation brief in a moment, but what I would say is it's out there in the allocation letter that some organisations have been given significant additional financial support. We haven't. So that might be something that we want to reflect on when we're talking to Welsh Government.
Thank you.
Just to answer two things, really. So what was clear from some of the national chief execs, and this is where I absolutely expect us to get to, is to have a bit of a fairly clear roadmap to financial sustainability, which it isn't, it's, but all of the things that we do and all of the changes we're making and the programs we've got, and we need to go further, we know that, but we try to map those out to show that kind of broad sustainability. Yeah. And I think being able, even if, there's a bit more work to do, I think having a clear line of sight of how we're making progress to that is going to be really key. And as the chief executive, I want us to get to that. So we need, as a board, we need to see that, don't we? So that's what we've got to work on as we go into next year. I think in terms of the targeted intervention, I agree with Rob, I think we're not completely clear yet what that would look like, and that's what we work with Welsh Government on. I think we absolutely got to use it as a positive opportunity for some support. The one thing that I have raised is, whilst we understand our own position very well, when you look at some of the metrics around our level of savings, we don't really stand out in year as a major spend outlier in year. So there's a big underlying issue that we know we are bringing through. But having some external support in terms of comparing some of our spend on particular high costs, our workforce, but you could be bringing your agency down, but substantive staff's going through the roof for, drugs, the CHC, the medicines, we're doing it in pockets, but understanding what's happening in other health boards versus ours to help us look at where perhaps we can target different or have some reassurance we're on the right track is where I would really value some further support from a national level. And I've raised that already because I think that can be beneficial to us going forward. So they were just two extra points I wanted to add.
Thank you. I think additional support or a different angle might be extremely helpful. But I am worried that targeted intervention usually means absorption further of executive time. And that's what I'm concerned about.
Yeah. So there's two other points that I think I will raise, because I want to have a better, more holistic, and I feed this back nationally quite a lot. I fed it back into our audit meetings. We really need to understand that demographic changing, the acuity challenge, the demand challenge. And I also raise this nationally. And again, there's understanding, is this the common picture everyone is seeing? Are we an outlier in certain areas? That helps us understand that we might be not doing something others are doing in terms of the prevention agenda. So really understanding our demographic and how that is impacting on our, our demand and the finance is also really important.
Yeah.
So whilst we got all the things we know we're going to do, the needs to try to reduce spend, drive efficiency, all of those. In parallel to that, I want to make sure we understand the drivers much more explicitly and how they compare to other areas to, again, see it as a way to identify opportunities. So that's another piece that I'm quite keen to really push on next year.
So we'll have a full report at our next meeting on the action plan.
Okay.
Ewan?
Yeah, I just endorse all that. And we should view it as an opportunity to get almost that support from inside the Welsh Government to see what we're doing. All of the, we see all the good statistics that we've got, the amount of money that we're getting per head and all the rest of it.
Yeah.
And it allows us to actually push that message into Welsh Government to say, look at what we're doing. Where is this spend going? But maybe we aren't comparable in some other things, and we should take that on board as well as a learning opportunity for us and be able to say, right, this is the area that we can target, etc., etc. So, as I say, we can either take this as a bad thing, or we can just embrace it and just follow it and use those resources as well. It's going to, don't be wrong, it's going to be a
but it is, and in all things, the conversations I've had with Welsh Government, it is about an opportunity to support, so I'm quite keen to make it that.
Yeah, well, it's important.
It will be
I'm sure it will be, but we've already putting ourselves under quite a lot of scrutiny. We're already taking risks. Some of the agenda today shows, it's quite tough. And again, it's also managing expectations about what we can deliver. There's I've had meetings with services recently, big push to say, look at our waiting lists. We've got to do more. We want to do more. We need to expand. Absolutely agree, but I'm ready money.
Because it's a scary challenge, when we look at our underlying, are we 80 million over on our underlying at the moment? Yeah. It's a hell of a challenge for us to get, we're about 5% roughly, isn't it? I'll spend next year. 80 million was that we'll go 6.5 million a month or something that we'd have to spend if we're doing this alone, kind of thing.
Yeah.
So we need that, let's make the most of that support. Take them on their word and say, look, you're going to support us, right? Then support them.
It's important we use it as an opportunity, but we need the right people in to add value to us.
Absolutely.
Hannah?
Yeah, and I would, having been in a few organisations that have been in TI and come out of it, I think the clearer we can be, and they can be with us, we can be together about what the criteria for de-escalation are as well.
Yes,
what risks and
just carry on.
Really clear on that.
Yeah. Thank you. Any further questions?
Can I ask, are we reassured then that this is achievable? Because we seem to have conversations, and it's whether the radical options are on the table, or will they be on the table, or is it, have we now been put into this category? The conversation before Christmas, and then there's something more into a different level. The amount of savings are considerable. Will there be radical options on the table for us to consider in terms of having to go down those particular routes if we need to? Can I ask the question?
Yeah, well, I think they'd be, I think as I've said, and I've said this previously, I want to focus on the areas that, like St. Lawrence, it's the right thing to do for patient quality, from the state point of view, and on the money. We know there's areas of big efficiency. We've got the fully effective things we've done this year. We've got the estates options. So what does all of that look like? How far does it get us? And then what's the territory we are in beyond that? And then we need to form the discussions from there. But, where I'm starting with is how long would it take us to recover the financial position, doing all of the right things? Or are we going to doing the wrong things?
I think what would be helpful, though, would be to have a time frame for where we are now with regards to, because otherwise we sort of the meetings, we can sometimes, it can be delayed, etc. So we are now in February 2024. We've got a new budget. So will there be a time frame of those sort of situations? So the time we get to potentially June, because they've actually looked at all that and we need to do more and we've got time to do it. So I'm just wondering the time frame, Nick. I'm hugely supportive of what you're saying, but is it enough?
Rob wants to answer, but next, the March plan needs to settle on his head.
That's what's got to be in the March. I'll let Rob.
Yeah. Yeah, I think that you got to look, but we're looking at top down, bottom up. So at the moment, the IMTP process and the request on all budget holders is what can you deliver within the resources you have available. Basically, the finance is the limiting factor. So we've got a process to develop that IMTP with an end date of the 29th for submissions to come in for consolidation and review. That'll give us a steer on what it means to achieve budget level spending. And you've seen from the finance report that there's a £56 million challenge there in simple terms ready for next year. Aligned to that then are the wider potential strategic top-down things we can do. So St Willis is one. So one division or one budget holder can't close St Willis. It's a corporate solution that needs to be put in place. And there's a few things like that being considered. So I think if we work through how the IMTP process or what the IMTP process generates, it'll be interesting to see what proposals, options, implications are coming up from core budget holders. It's in the service, that's corporate as well, for everybody to see how they can live within their means. And then we've got this top-down approach. I think the top-down approach is probably where the more radical things will emerge, but we need to balance both then in terms of patient safety, et cetera, et cetera.
Gavin and then Hannah.
I think just from my perspective, one of the things I'd really appreciate for one of the next meetings is when the minister in the Senate yesterday said that we haven't gone far enough and we're not making enough progress. I'd like to understand what it is they're looking for from us. So let's say the language that Eleanor used in Senate is we are not making enough progress on our plans, and I'd like to know what progress looks like from Welsh Government's perspective. And I suspect that's a how long is a piece of string question, but
so just on that, so I think I haven't got the numbers in front of me now, but I'm going to do them off the top of my head. So if you take it the level of savings achieved by each organisation, we set a hugely ambitious savings target of 51. We knew we did, and we put in a 10 million innovation reserve almost as a bit of a buffer. And so we see as one of the health boards furthest away off our savings plan, even though we had the biggest savings plan, double what any other health board had. So we've reported an achievement of 42.9. I think the next highest is 27. So we are saving in excess of 10 to 15 million pound more this year than any other health board is reporting. Alongside that, we've obviously got operational pressures that are coming through. Others will have as well, but it's a different level. So I do think we've never saved that level of money before. And I don't think the recognition for that level of saving is probably, because ultimately we've got a big deficit and we're furthest away from the control total as a result of the aggregate of things that we are doing. And that's where I will welcome that support to really drill down, to kind of recognise. And I know some of the conversations we've had is, you are doing lots of things, probably more than other health boards are in terms of some of the changes that we are trying to make across the system. So, I think the comment is in the context of the numbers just not supportable, it's too big, rather than what I think is a recognition that we are not trying.
I think part of this needs to come back to some of the conversation we had earlier on about making things simple. We're using a lot of words and a lot of information to describe why we are where we are, and it feels like that's not sinking in places. We get less money per head of anywhere else in Wales. So we get less funding than any other health board in Wales. We have also cut out more money from our system this year than any other health board in Wales. And yet we're not going far enough. And I think, according to Welsh Government and the Minister, and I think we need to find a way of being as clear as that in our communication back to Welsh Government and the public. We get less money than anybody else, and we cut more money out than anybody else. And we are still in this situation. I think we've got to find a way of cutting through the language we're using and being as clear, probably as blunt as that. Because otherwise we will always be pulled up as not going far enough and always being hammered for being over budget.
Yeah, so just to correct, so the work we did where we did a 3-year review recently, and we looked at people's spend levels. The last set was 22-23 was the latest. That showed we had the second lowest spend per head. So Cardiff have got, just to be really clear, because I don't want to, but we'd had the second lowest spend per head with a very different population. Yeah, because you can't ignore the type of populations we have in the health board, and that's a bit about understanding our demographics, understanding the acuity. You know, we've been through over the last few years a funding formula. There's arguments about age, there's arguments about morbidity, rurality. So we can, but ultimately, when you just look at spend for a health board, we are on the low end, despite the challenge we're now in. So I think it is really important for us to understand that as part of our look forward.
And our response. Yeah.
Anyway, oh, sorry, Bill. I just wonder whether one of them, the missing issues for me really is the performance comparator. Yeah. I mean, you can spend more, you can spend less. The issue is, well, how does our performance compare? I mean, if we're spending more money and our performance is better, well, you can see a line of sight there. If we're spending more and our performance is comparatively worse, then I guess we're in a more serious place, not the.
Yeah.
So I guess that's what we need to do, to look at what do we get for our money compared to other people.
Yeah.
And I don't see that in this debate with Welsh Government.
No, absolutely. And there's no doubt, you know, the Grange being, you know, and the new model is costing us more money. Oh, yeah. Because we haven't driven all the benefits out yet, because we're still trying to recover from a pandemic. We know that hence some of the work that, you know, Leanne and the team are driving forward. We know, you know, it does fluctuate, but we have seen improvements in the clinical mortality, which will be better than other parts of Wales. Yeah. Not all, but some, and many. If you take planned care, there's quite the report that was produced by Welsh Government on performance. When it looks at planned care, it's really good because it adjusts for your waiting list per 100,000 population rather than just looking at absolute numbers. Because when you look at absolute numbers and compare this to a population that's almost half the size, it doesn't actually mean anything. But they do adjust for it per 100,000 population. And on planned care, we almost always are towards the lower end. So the amount of people on our waiting list per 100,000 is either the lowest or second or third lowest. So, you know, the areas which we'll pick up, you know, we stick out to the minute is a little bit on some of our urgent care. But again, when you adjust for volume and population, it's not as bad as it looks when you see it in absolute numbers. Not defending that we've got issues to sort out. So I think you're right, really, you know, that comparison to what you get for your money is, you know, yeah, okay, we'll spend less money, but increase mortality. That's not a great result either, is it? So I think, you know, you are right. I think the work going forward has got to put the more holistic picture together about why we are where we are, what our opportunities are to go forward, and then what the choices are that we might have to make, but understanding the impact they would then have on performance. Yeah. You know, because one that's very clear in the performance is we've gone from being the best in diagnostics for 8 weeks to being one of the worst. We made a very informed, risk-based decision to reduce costs, which has meant the ultrasound MSK, you know, type of low risk ultrasound's gone up, which we're trying to recover. But, you know, if you just look at it as a blank number, you've got works where we're trying to juggle all these other things, make risk-based decisions in the context of the financial challenge. So it has got to be a more rounded, holistic conversation going forward, I think, about where we're at and where we're going.
Well, and a more realistic conversation with our own people then as well,
Yeah,
isn't it? I mean, if we know what our outcomes are we're getting for less money, then it's a good place to start with the conversation. Isn't it?
Exactly. Well, let's hope that the health meets it will enable us to the time and space to do that work, because it is absolutely imperative we manage our services within the financial and staffing on to a good quality and to meet the needs. And that's what we've got to do. And we have to do everything possible to achieve that. So any support that's required, you've just got to ask the board. And obviously we will have experienced 2 months of intervention by the next meeting, and you can tell us whether or not it's proving to be as supportive and helpful as would be useful to us, and also what is the de-escalation level, because that is always a bit of a loose figure, isn't it? Yeah, thank you. Okay. Yeah, we've done the allocation. That's all. Was that a long time ago? No,
We've probably done the biggest issue in there, but
yeah, go on.
So in terms of the papers for the board, you've got an overview brief and a more detailed briefing of the allocation letter that we received late December. If anybody does want the full publication of what we get sent, please ask. But the interpretation of it isn't straightforward, hence these briefings. So the aim of the paper is to provide clarity on the allocation income and resources that we have available for 24-25, most of which in the allocation letter are recurring. So whilst this is a focus on 24-25 is a guide for the likely funding for the future. Obviously, we've touched on our financial position, and just a reminder that statutory duties to balance financially over a rolling 3-year period, which for us is a challenge, and I won't repeat that. So in terms of the briefing, it's the inclusion of what's in the allocations for Aneurin Bevan. We've also included some anticipated income where we have allocations that may not be in the allocation letter per se, but are fed through every year as a matter of course. So we've built those into the clarify the total resource envelope of funding we've got. In terms of those anticipated income and allocation items, as a rule of thumb, we apply a certainty parameter around we'll recognise income or allocations if we get a formal policy communication, policy lead communication, or a letter that says the fund from Welsh Government that funding will be forthcoming. They then convert to a confirmed allocation with no risk when we actually get the allocation letter itself, which is in a set format. In terms of some of the key anticipated income values, it'll include things like pay awards that haven't been confirmed yet. So we'll assume, or we've been told to assume that funding will be coming through. So for our INTP process, cost of pay awards, we can assume will be covered. That's a big one for us. In terms of the big picture, then we've had a £156 million recurring uplift, broadly 3.67%. However, about £116 million of that is a reflection and recognition of funding we've had during 23-24, now built in formally and recurrently into our allocations going forward. That gives us broadly a £51 million new uplift, but we have earmarked approximately 11.5 million, which we are obliged to pass through to our NHS providers, where they don't get their own allocation uplifts for where they provide services to others. That's a trading arrangement, so we have to allow for that. That is subject to negotiation, and as you can see, is quite a big figure in the context of our funding at 11.5 million. That subsequently leaves us with £40 million like for new discretionary investments within a total funding envelope of 1.636 billion in terms of the allocation. It is a bit high, and I'll come on to that in a moment. So That 40 million will also need to cover our inflationary cost pressures, other commitments we've already made, as well as anything new we may want to cover, as well as our underlying position. So I'd describe it as new discretionary, but broadly, we will need it to just maintain our current service profile and go further with savings. The big issue to flag would have been the conditional recurrent funding. That's the biggest sum we've had, 64.5 million. I won't repeat the debate we've had at length because I think we've covered that, but happy to pick up questions if there are any at the end. I've mentioned about pay awards to be confirmed and assume they're a neutral impact risk in our plan. We are required to identify at least a 2% CIP plan. So for us, that's £33 million. But it is mentioned that our savings levels should be closely aligned to what we did in 23-24. So 33 to 42 would be broadly expected. And as we work through the INTP, we'll be working at what we need as well as what's expected. Primary care contracts, GMS, etc., are included at funded levels for 23-24. That's a usual thing until the contract negotiations conclude during 24-25, and then we'll get an uplift to reflect those. And as a host organisation, 111 and the 6 goals funding has been removed from us as an organisation. That's £20 million. That's neutral impact. That's as a result of shifting the management of that to the NHS executive. So to summarise, the confirmed allocations in the allocation letter, 1636 million. Anticipated income and allocations of 64.7 million, and income assumed, which is largely medical training and postgrad type costs, 11.7. So it gives us our total IMTP resources for income allocations of 1713 million. As I say, there's more detail in terms of anomalies and more detail in terms of specific funded lines in the report itself. I'm happy to take any questions.
Thank you. Thank you very much, Rob. Are there any questions to Rob? No positive news in this allocation letter. I'm a little sorry to see ring fencing continues. We had asked that it might be removed, but there are obviously reasons why that was not seen to be acceptable. But it does mean that the discussion we've had for the last hour will be intensified over this year. And we are really going to have to make a big stride forward to be able to live within our means and protect patients' quality of care. Okay. Sorry.
So just so I don't disagree with the challenge, but it was better than I was expecting.
Oh, ever the optimist.
Yeah, of course. But you know, I think what is going to be key is about how inflation looks and how we manage to contain costs and deliver more savings. Because I think if we can contain our costs within our savings level, then we can use that allocation to go towards our underlying issues along with that money. And you know, I think we've got to do that through the work with the outlook, and some of the things we've seen this year operationally are challenging. But you know, I mean, in terms of, you know, I was worried we would get no kind of net growth, and it'd all be just covering minimum inflation issues. So we'll do the work, but I think compared to other, you know, parts, again, there is recognising the government's position, there is commitment recognised for the NHS. It's never going to be enough. No, but I saw the optimism in it.
Jolly good. Yeah, thank you. Okay. The performance report. Anna, you get all the good.
Sorry, it's me again. Thank you. So members will be more familiar with the format of the report, that's the quarterly outcomes report that comes after each quarter, that uses the life course approach, updates on the clinical futures programmes and ministerial priorities and where we are with INTP commitments. Notwithstanding some of the feedback from the structured assessment, we've got more to do on that. But what we've developed in response to feedback and our own internal audit was around the needs in between those quarterly performance, those quarterly outcome reports, to be a bit more succinct and clear in some of our what I'd call the more traditional performance reporting. So colleagues in the F&P committee will have seen this layout, and just to say this is in the most part the report that went there, with obviously a couple of data points and updates on actions, etc. So it is framed around the sort of systems or areas of care that align with the ministerial priorities, so planned care, children and young people, etc. And we will be, even though it's a new format, so keen for feedback. There is still, as you'd expect me to say, probably iterations we want to make in terms of the metrics that are in, some feedback on, like, let's look at 12 months of data points rather than just this year's, make sure we're picking up, not misinterpreting themes and trends. So still further work to do on this. And also just to note, Paul's team have worked on a dashboard where we'll be able to pull some of this information directly in as well. So that's what's really welcomed, and we're grateful for that as well. So in terms of content of the report, other than the format, I just want to put out a few points under each of those headings and then open up for questions, if that's okay. So on planned care, Nicola's already touched on it in the Chief Exec update, but I do think it's important to note here the really good progress the operational teams have made in trying to, again, as close as we could, on eliminating rates of over 156. So it did end up as 44 at the end of December, as we pointed out at the beginning. Just to note that there's a whole new sort of cohort of patients now. I guess of January, there's more patients in that cohort. So efforts on maintaining that, and that's a challenge. It's not sort of a given. The numbers aren't low. There's still the sort of the blocks and numbers coming through in these cohorts are quite big. So lots to do, and it's great to be the best in Wales on that. In terms of planned care as well, not in the report, to note that we will see now, we are already seeing the impact of the implementation of the regional cataract business case. So I think, what did we say yesterday, Lam? Was it 4 weeks have come off cataract waiting times in a week, based on some of the work done, outsourcing the action there. So that's positive. And we can see some of it already, but we've seen the impact, starting to see the impact of the endoscopy unit as well. So that will come through in future reports. In terms of cancer, the main thing to point out, cancer is an error, apologies, in the actual figures. I'm pleased to say it's an error that, now corrected, is improved. So the actual figure for October, single cancer pathway performance is 59.3%, and for October, which was down as 58.4%, is 60.4%, and for November is not 53%, it's 59.1%. So there was a bit of an error or a lag in the validation, but I'm just pleased to report an update on that. And I think in terms of cancer, where there has been an absolute focus of the teams is on the backlog of patients, and which by definition will mean that they're not being treated within time. So I think it's positive to maintain more or less 60%, whilst also getting the backlog down in the face of increasing referrals and also being able to deliver increasing numbers of treatments. So start to bring that forward as well into the report. The next section, in terms of children and young people, maintaining the no waits over 104, but the actual numbers on the waiting list are creeping up, which needs to be monitored and a bit of a cause just to keep an eye on. But there is positive in terms of the CAMS performance against the measures that they are being sustained. The main risk area against children and young people is around the ND service. The report sets out the actions that are being taken, and that's being tracked through the divisional assurance reviews. We've picked up a few times today about the urgent emergency care system. It is still under significant pressure. At the moment, the metric in this document around, we talk about patients on the complex list. Earlier on, Jenny was talking about numbers of delayed transfers. We do have work to do to validate and refine how we're capturing, how we're reporting. I think it's fair to say, isn't it, Jenny, in terms of those numbers. But at the moment, Jenny referred to earlier those that are done in that monthly audit. So we've seen some improvement, but it's not the gains to which we would like to see. But in spite of the pressures in the urgent emergency care system, and as Nicola touched on earlier, we are still performing well on 4-hour performance and on 12-hour waits, but absolutely not complacent on challenges. And as you will know, and especially we had it anyway, but especially in the face now of the escalation, huge focus on urgent and emergency care. The area probably of most challenge remains with our mental health. We know we've worked through issues associated with the WICA system, and so now performance remains a real challenge on all measures, both 1A, 1B, and on the psychological therapy input. There is an improvement plan. We're coming to the end of the 90-day improvement plan, and there are actions outlined within the paper, but I think it's fair to say this remains a key concern for us. And I think we've got a focus session tomorrow. Is it tomorrow? In execs on the mental health improvement plan around this performance. So we're focusing on execs as well. And last but by no means least, we're trying to introduce, recognising there's not an awful lot of targets around primary care. And admittedly, these are activity indicators rather than outcome or impact, but we see it as a bit of a step forward in having anything in here in terms of primary care. And we have got further work, as I said, to do in terms of describing the impact of these interventions and services on the system. So further work, as I said before, in terms of our iterative work. I'll pause there if that's okay, because I'm sure colleagues will have questions, but and myself, and I'm sure phone a friend if I can't answer all of them.
Yes, my question is more of a comment really, and it's just on the layout of this and changes. I have to say, I just wanted to say that I think it's a really improved paper, particularly because we've had a lot of performance papers in the past that tell us what's happening, but they don't tell us what that actually means and what's happening. You know, the kind of so what question. You get a lot of figures in front of you, and what does that actually mean? So I'm really pleased to see the action points in here, and for me, I think some of them just describe what's happening without saying what the intended outcome of the action might be, and that might be just a helpful thing to add.
And thank you, it is, and the timing of the action.
Yes.
Yeah.
Thank you, but it's much easier to read.
Yes. Thanks, Pippa. Any further comments on this? I mean, there's some very Who?
Sorry.
No, sorry, I can't see you there.
Sorry, I need to be screwed stuff around. Just a comment on the mental health issue, I guess. There's clearly lots of challenges in the report. There's some good things that are challenging. The most concerning area for me was mental health. I just wonder that as our mental health service is a multi-agency service, really, I wonder whether it would be useful if we could agenda this at the RPB leadership group as a specific issue. Because it's not a single agency response to mental health, is it? And maybe even filter that through in a report to the RPB. But mental health doesn't feature very heavily in RPB land, and it doesn't feature very heavily with council. But actually, it is a serious part of their work. And I wonder whether it would be useful to raise it in a different place. We can't fix mental health.
No. Yeah, we can do that.
Yeah, I think that's in the CAM space as well. The ND work a lot.
Yeah, same issue. Yeah.
And it's probably worth having somebody like Wendy Gunny come on the right care, right person aspects of how we integrate with police and local authorities in terms of supporting mental health crisis. Maybe that's something.
Much of our problem is responding for assessment work, isn't it? Which is definitely within the arena of government.
Yeah. I mean, if I may, and I'm sure I'll come in. there is, and it does need a multi-agency response, but there is absolutely things within our gift. I think we didn't know.
Oh, absolutely. No, I agree.
How we, employment times, efficiency, processes, mechanisms. Where that I would welcome that focus. I think as well as sort of focusing on what is within our gift. I think certainly from my early observations from being involved in the division, I think we've made the most of that mental health sort of strategic meeting that sits sort of beneath RPB, and there's lots of knock-on impact around the position we find ourselves in around partnering with not just local authorities, third sector, but alternative strategies. So I think we really do need to strengthen the offer in that meeting to feed into RPB.
Yeah. I mean, if you're looking on a regional partnership board, it features heavily on older people.
Yeah.
It's on children. Very, very little on that.
Yeah, it's true. If we're not meeting the performance targets in mental health for a variety of reasons, why are the variable costs going up?
Some of that will be related to staffing of our inpatient units, enhanced care, vacancies. There's a significant amount of work for us to do on the workforce plan, I think, in mental health across multiple professions, as well as the configuration of our mental health services. It's a bit of a recurring theme. I think there's an absence of a strategy for mental health within the health board. We are out to advert for the divisional director at the moment, and it's really important the divisional director's in post, I think, to be able to own and drive that forward.
Yeah.
So I think when we have that appointment made, we'll drive forward with the progression of a mental health strategy.
And LD, good. Well, it needs doing to get this. Thank you. Okay, final comment from me. I'm awfully glad that urgent primary care seems to be being used, because it was a bit of a quiet spot. So that's good. And why do we think that is?
There's more, I think we've got more integrated working across the system. They sit and offer, they observe on some of the cross-system meetings, the pressure that's in the system. My belief is that there's more that they can do still across our urgent care system, but I think the enhanced monitoring will give us that opportunity, I think, to really expedite that work further as well. And we've got quite an engaged workforce there. We've got a new CD in that area too, that's come from Cardiff, actually, I think, bringing some new ideas. So I think there is more opportunity there still as well.
Good, but it's good to see that it's taken off.
Listening to that, we underestimate it, but how great is it to have primary care data, even if it is giving numbers of appointments?
Yes, it's true.
But to be able to report we had 70,000 more appointments provided in October than we did in April.
Yeah.
I know we haven't got the whole year in, but it's a huge step in the right direction to actually have, and we had that discussion with this executive team. So I just wanted to acknowledge, there's more work in this space, but to have some data, given the public no angst about primary care. It does show we are improving our access, which is one of our key issues. Key.
Could I just make a point along the same lines? The data is one thing when you look at it, but during the Christmas period where we're really pressurised, there was one day where the PCC call centre took 1,035 calls, and they were also taking from the 111 stack. And for a brief period, they're also taking the 199 stack.
Okay.
So can you imagine not having them there?
Yes, quite.
Given those sorts of volumes, the work that they are dealing with, and we get almost no incidents arising. They've got a really good internal escalation policy where they match the number of staff to the activity levels, and I think it's really impressive.
Well, I'm really pleased because everybody's tried hard to get the service off the ground, and it's good to see that it seems to be really playing a fundamental part of the system. That's good. Anything further? Okay. Health and safety fire improvement plan. We're stopping in 10 minutes.
10 minutes. Right. I like the challenge.
Yeah.
Thank you, Chair. In November, the board received a report on health, safety and fire, which identified 7 areas of risk for the health board, including compliance with health and safety legislation, but also in achieving compliance with the health board's own performance standards. The purpose of this update today is to provide the board with an interim statement on progress with the improvement plan, which has been put in place along with enhanced monitoring since November. The 30, 60, 90-day plan, as we call it, the improvement plan the implementation started in December and will run until the end of February. It has actions which address the immediate risks, aiming to deliver improved compliance with the legislation. Importantly, we have quantified those risks, and the risk report is one of these things, but that has also informed the strategic risks, which will get mentioned in the next item on the agenda. The strategic risk is 16, and we're working towards a target risk of 6 within an appetite threshold of 8. So you can see where we sit currently, but where we are working towards. On completion of the 30, 60, 90-day improvement plan, a longer-term programme of work will then be considered by the Health and Safety Committee with the aim of not just achieving compliance, but sustaining it. And I think it's that thing about it's never finished, and the work then continues. I would say, on reflection, a common thread that runs through our improvement programme is really about working differently and implementing a different approach to health and safety in the organisation, and really working much closer with divisions and directorates to help them to deliver health and safety compliance, but also to hold them to account as well. And that's kind of the thread of the report. There are 7 areas of risk which we focused on. I will go through them very quickly, mindful of time. Manual handling, training compliance at the end of November did marginally improve, but it is not at the 85% target that we're aiming for. And some of the key areas of work we're looking at is looking to review the manual handling training programme that very much prioritises high-risk areas and high-risk roles. And therefore, what we'll get from that is a better, more intelligently informed frequency of training, rather than just a blanket approach where we ask everybody to be trained at the same frequency. And that's not helped us in the past. There are some very practical things we're doing around manual handling, looking at accommodation, where we provide manual handling training by the corporate health and safety team. We've also started and started commissioning external providers for face-to-face manual handling training as well, just to increase our in-house capacity. But we will also be working really closely with divisions to directly monitor divisional compliance with their training. The majority of manual handling training happens in the divisions by cascade trainers. The corporate health and safety team will really provide the training on induction specialist training. So we must support the divisions with their capacity so that they can be compliant, but also monitor it. The secondary risk was RIDDLE reporting, and that very much is about reviewing, updating and communicating the Health Board RIDDLE reporting guidance and providing additional education and awareness raising throughout the organisation. We are implementing a performance and compliance dashboard, and that will improve and increase divisional monitoring and accountability, and which will feed it into divisional QPS forums and into the divisional assurance meetings. So that way we can have a direct conversation with divisions and directorates about what their RIDDLE reporting compliance is, and really get to the root of the problem if there are gaps there. Next area is health and safety monitoring. This really is about workplace inspections. The improvement plan aims to complete all workplace inspections on acute hospital sites by the end of March, and we've set ourselves that target now to do that for all acute hospital sites, and then to follow that with a rolling programme of audits and inspections from April 24. We will be increasing the capacity of local teams to undertake local inspections. That's what we want to achieve. We want that being done locally. And so we're developing an inspection protocol and various tools to help that local inspection to take place. We're also now using the AMAT system to record and monitor workplace inspections and actions, which will help drive the completion. In terms of health and safety risk assessments, we were concerned about the quality of the risk assessment being undertaken. This very much aligns with the conversation we had earlier about the risk management framework and how we ensure we have the capacity and capability in the health board to undertake really good quality risk assessments. Importantly, at a local level, and so improving the guidance and training programme, and that's a key plank of the improvement plan. The divisional level self-assessment, which we've committed to undertake, will then probe whether divisions have the required resources and skills to undertake the workplace risk assessment standard we expect. And that will be completed and lead us to a targeted improvement plan in divisions and directorates. And we can then work to improve any gaps there. Those last two areas of risk were also the areas of risk that were identified in the internal audit where recommendations were provided. So by driving the improvements in those areas, we are looking then to close down those internal audit recommendations. And I'll be going to the audit committee in February to talk specifically on those recommendations on papers. There are three risk areas then related to fire. One is about fire risk assessments, and we, through the improvement plan, we developed a dashboard which has now been implemented and enables us to now provide weekly monitoring of fire risk assessments. The register of fire risk assessments will now be validated, which will then allow us to review our compliance framework. And this again is about more intelligently determining which areas of the health board, which departments, which buildings, which workplaces need a certain frequency of fire risk assessments. So instead of like a blank approach in the past, if all got to be done annually, we'll take a more risk-based approach based on the function of a particular building or unit. Fire alarm systems, we've touched on that briefly earlier with the capital programme. Where we are at the moment as the key plank of the improvement plan is gathering intelligence and requirements to replace the fire alarm systems over the next 5 years, which will then inform our ongoing capital replacement plan. What we do know is from the surveys that have been done is that the Royal Gwent and St Willis, the fire alarm systems, while fully functional, are end of life, and that's why they feature in our current capital programme and are a part of the key work. But it's really important as we move forward, we understand where other sites may need replacement and we get the intelligence on that and feed that then into the capital programme. Very similar to that is the seventh risk area is fire barriers. We already have improvement schemes being prepared for Neville Hall and St Willis, and that's based on our intelligence from site surveys. But the main plank of our improvement plan is to do further fire compartment surveys, which will then lead to a structured system of managing compartmentation. And we'll be working really closely with facilities to then develop the capital bids that fall out of that. I guess probably our main area of focus right now is the Royal Gwent, because we understand the risk in Neville Hall and St Willis. So the survey at Royal Gwent is the next major survey to be taken. And then they're the 7 risk areas. But besides that, on top of that, we've done a lot of work in our improvement plan around governance and oversight. That's kind of overarching. That involves the completion of the health and safety risk assessment that's been completed since the board report in November, allowing us to quantify the risks and get deeper into them. That's then informed us registered that we'll come on to on the next agenda item. I referred earlier to enhanced monitoring, and that's an approach I've taken in response to our concerns in November. So I now have a weekly meeting with Scott, our head of health and safety, who I can see is observing the meeting today. And I'm taking reports every month to the executive committee on our progress improvement plan. So it's like a level of an enhanced monitoring that I've put in place. And we're also reviewing the health and safety governance framework, and which includes updating the health and safety committee in terms of reference and membership. So really looking to strengthen the governance and accountability within the organisation around health and safety. And I'll just go back to that and kind of finish on that final point. Really is it really does amount to a different way of working for the health board around health and safety, really building those relationships and really understanding with divisions and directorates about how they can play a part in improving health and safety compliance. What's become clear to us is we can't deliver compliance if it just depends on a very small corporate health and safety. I think maybe that is the key learning from where we've come from. Thank you, Chair.
It's definitely about the accountability and where it goes, and knowledge and understanding. Thank you very much for that. Are there any questions? Helen?
Just like to acknowledge, obviously, a huge amount of work that you and Scott have obviously done to get this far. And obviously, I think one of the things I was going to raise before was the staffing issues, but you may have actually addressed that by saying by actually getting the divisions involved, they're actually, so they've got ownership rather than a set number of people who are labelled as the health and safety team. And also linked with that, probably I was also going to question about the manual handling and being external source, which would be very expensive, but perhaps that's only for a minority of cases if most of it's delivered in-house.
Yeah, that's right. The majority of manual handling training happens in divisions of directorates. So we provide that at a corporate level at induction for new starters, and we do that as a face-to-face classroom. It's a bit more enhanced than because they're new starters. But also anybody working in very specialist areas where they're, for example, required to lift patients through voice and things like that, they need a specialist level of training, and we provide that as well. But the vast majority of manual handling training that happens for most of our staff happens in the division directorates. We need to make sure that division directors are equipped to do that, and reposition the health and safety team to be much more of that oversight, monitoring, audit, that, but also the experts, guidance support.
Just on that, I just popped into my head, if most of that training is being carried out by the divisions, are we sure that the record keeping is accurate? So that is it possible that more people are getting manual handling training than we actually know about?
So we gather our data from ESR, which is our staff record system for all of our training, not just manual handling training. You have to rely on the individuals updating themselves that they've had their training. And, I, as an employee, have to go on ESR and make sure that it's been recorded and it's been updated. It's only as our intelligence is only as good as the system. So Scott and his team do work really closely with the ESR team to make sure that data is clean and it's valid. But it's as good as the data.
So, is there something around making sure that part of the training we deliver is to tell people that they need to update ESR?
There is itching to come in.
I think probably as you've raised that question, Pippa, triggered something in my mind as well. And you and I have discussed for a little while the need to simplify the routes to training and what training looks like for our different staff groups. I think this may be something that we pick up with our newly established core learning committee, maybe to look at this specific issue in more detail. What paperwork are we using? Is that causing any barriers in terms of recording? I would guess that it is to some extent, but I think that's something we could ask the core learning committee to pick up. And just to give some assurance as well, there are dual aspects to training in terms of fire and manual handling, and partially that's delivered for online learning for all staff, but particularly for admin and clerical staff, and for fire as well. And compliance with those modules online is very good. It's over 80% for all the modules, which is higher than our overall statutory and mandatory training. So just wanted to add that point as well. But in terms of your question, I think it's a good point and something we could ask the community.
I perhaps failed to mention as well that the majority of staff could get their training online as well, and that's what we must make sure that we're not unnecessarily providing face-to-face training, and making sure that we maximise online.
Okay. Ewan?
Yeah, I think this report is quite a good step forward from where we were in November.
Yeah.
Personally, I didn't get any assurance from our report, and I think this gives us a little bit of assurance going forward, and it's a good place to build. There are some worrying comments in the report around the fire safety stuff, and the fact that it's obsolete, etc., etc. etc. But we've covered that already.
I should correct, it's not obviously, it's it's moving towards end of life, and if we don't replace
Okay,
it,
so it's obsolete. That's all. And there are other things about health and safety monitoring being inactive for a number of years, etc., etc. I would caution us on leaping forward in reducing our risk levels for some of these things based on the actions that we're taking. And I think given where we were, I think we should be focusing on outcomes. So if it is, mentioned and it's back to got auditors in the room, if we don't record, if we can't prove it, it didn't happen kind of thing. The actions we've got there will facilitate that training taking place, but I think we should be looking at how much training took place and where we're at and what good looks like when we get there. And that, I think, was with a lot of these, because I think it'll take us a while to get from where we are now to that compliance bit. So I wouldn't rush to reduce the risk on these things. So we can prove that it's in place, and that's with an eye to internal audits coming about in the next year.
I would respond to that by saying I completely agree, and our compliance can be quantified. So training compliance, middle reporting compliance, and they're really clear targets that we're working towards. So I completely agree. We can only reduce those risks when we can see the compliance improve.
Yeah, it's just got the here's the actions rather than this is the outcome that we expect, and that's when we reduce it.
I don't disagree.
Given where we are,
I completely agree.
Good, thank you. Any further comments? No, we break for half an hour, please. Shall we continue? And thank you for your indulgence in having a short break, but we have been going for an awful long time. Could we go to the strategic risk report, please?
Yeah, I'm going to pick it up because I was
Yeah,
so obviously this is a fairly standard report now, thanks to Rami, and at the last meeting we'd updated our risks to 9 strategic risks and 19 sub-risks, which I'll bring it off the top of my head. Obviously, since the last board meeting, there's a number of issues that have emerged that has resulted in a proposal to make some changes. The first one is on the back of the progress we've made around some of the safeguarding training, there's a recommendation to reduce the risk score on this one. And then there's 2 then we were planning to 2 kind of sub-risks that we would introduce. One is on the back of public health funding not being confirmed. Are we concerned about the sustainability of some of those services? Therefore, I've suggested that this is a risk. And then the other one is just kind of brought out the regional services and the fragility of regional services. And this particularly has come to light on the back of some recent discussions we've been having with Swansea as well around the sustainability, the fragility of a number of our services. And there's work going on across the, the super region around making sure we're really clear on where fragile services are. But I think we've got more to do around the maturity battle going forward, which is why we've identified it. I think it's important because even if it's not our services that are fragile, the need for us to support others will impact on the whole South Wales service, which is why we've put that on. And then the other one, which you're familiar with, is the introducing health and safety into the risk register, which I think we all had at the last meeting on the back of the work Peter had brought forward that we should now include. So based on that, we are now proposing that we should have 10 high-level strategic risks and 21 risks.
Thank you. That's right. Yep. Okay, thank you. And thank you very much for such a very clear report. It's been a lot of hard work, but it's really important we have a grip around the issues. Are there any questions? No, I think they're all well understood. And are we content with the actions and the mitigations in the report? Yeah, do we think they're going to work? We hope. Yeah, So we'll have a report at our next meeting on progress. Thank you. Okay. The vacant GP practices.
I'll help the agenda along and just sort of share with you that the vacant practice paper is included as a summary of the action that's been taken by executives and agreed by executives, and it's just for notice. Clearly happy to pick up any queries offline or
Thank you. Any questions?
I've got some questions about some of the commercial aspects of this, which I'd like to pick up.
Take them in conference. Yeah, we'll do that. Okay, well, thank goodness we have been able to secure the future of these practices, but we must maintain vigilance in terms of the outcomes for the patients and do a proper evaluation of whether or not we're getting what we expected.
I can provide some early feedback. I think it's really important. I know Gemma's on the call. Place have been very vocal in the support of the contractors that have taken over the contracts, actually. And I've got personal family experience of being treated as a patient within one of those practices, with regular patient surveys being sent out, regular reviews happening in a much more structured and timely way than previously before. So Place have actually been very vocal about the quality of the individuals that we have managed to secure as independent contractors.
Good.
So absolutely, we will remain vigilant on that. We know that we will have steady partners in place in being independent assessors of that.
Oh, that's really good news. Thank you very much indeed. So we're happy to note and endorse that, and we will get regular updates. Thank you. 4.7, the RPB.
Thank you. This is just the usual updates to update colleagues on the work that's happening within the RPB. I think we might have touched on it at the top of the meeting. Then since we last met, I think we'd had the workshop when we last met, but there's the board was at the end. The RPB board meetings at the end of November. Just a couple of areas to pull out of the report. The work on responding to the governance review is continuing. Progressed in the task and finish group chaired by the chair of the leadership group, who is the director of social services, Gwent. There's within the report, it shows the themes and headings that came out of the first of what I think will be a series of or a number of workshops to respond to the requirement in there or recommendation that the governance review around looking at priorities, focus, intent of RPB, and a bit picking up the point that the chair raised in her update around alignment with PSB. So work is progressing there. Since our last report here, there has been a huge amount of work done to comply with the Welsh Government guidance on quarterly reporting against the rift. So that went through the RPB at the end of November. And we've had some positive initial feedback from the Welsh Government. I think as well, there was a bit of a realisation of the work and detail that reporting was driving, and a bit of a challenge, I think, for us in the RPB, for us in the board and for Welsh Government, also wood for the trees, really, because the guidance generated a huge amount of work, but it was still arguably in some places quite difficult to see.
It was very, very difficult. It's not giving us the message and the information we require.
Yeah, so I think Welsh Government have picked up on that. Again, the chair's update talked about the need to do the evaluation and impact assessments on RIF funded schemes. That work, a two-phase approach, has been initiated and will be coming back through the RPB. It's important anyway, because it's important we're targeting money at biggest impact. But was obviously made more focused around the issue around tapering. I've had unconfirmed reports that today it's been confirmed. Does that make sense? I've had informal that the tapering will not be implemented.
Yes,
in the meeting. So I haven't seen that formally come out, but that doesn't negate the need for us to do that robustness, because it's important from our partners and the system that we target that investment at. biggest impact. And then there's just a bit of an update on where we were with the financial allocation, but I think that's been picked up through Rob's update as well. There's been lots of activity since we last met around planning against the further faster funding that's been initiated. Money to come to the health board, but work its way through the ISPBs and to the RPB. So lots of activity there and agreements through the leadership group around some non-recurrent in-year allocations, as well as some recurrent allocations, which are our, I think, and I'm sure Jen will come in, but will help some of our local priorities as well as partnership priorities in terms of community, community resource teams, community nursing, end of life care, and all of that linked to our joint ambitions around acute frailty models. So some really positive work there as well. And the next meeting, we have an RPB meeting next week, I think. So some of the most immediate issues will be picked up again in that meeting. So that's all I'll say.
Thank you very much. Penny?
Sorry, can I just ask for clarity? Did you just say that tapering wasn't going to go forward now? Not going to be done?
I think that's going to be confirmed.
Right. Okay. I'm not going to spread it. I just didn't hear what you said. Okay.
That's the informal feedback.
Right. Yes, it will have been discussed in that in the last half hour, because the minister was holding a meeting with the leads. And thought, well, I couldn't go obviously because it was here. But I'll find out at the end of this meeting what's been suggested. Any questions? I'm glad that they've seen a little sense, although I don't think we went around about it in the right way, the influence of the government in terms of returns, because they certainly don't tell us what we need to know, and they certainly won't tell the minister what she needs to know. So I think some sensible conversation with the right tone is going to be important.
Yeah, and I think that's the way we've approached it. Let us help you. We'll, because our experience of this, and it's been hugely resource intensive, and as we witnessed in the RPB, we don't get the RPB and what we need from it. So I believe that Welsh Government would too. So I think they're receptive to that.
Good. Oh, that'll help, I think. Thank you. 4.8, the Executive Committee Chair's report.
Thank you, Chair. In the interest of time, I won't go through it all. You'll be pleased to know I'll just pull up one or two headlines. We had a useful discussion at execs on WCCIS and the strategic direction of travel nationally, where we kind of set out kind of our broad desire. We're going to do a session with the board in the next month or so, just so that we get a bit more of a strategic position around national versus local and kind of some principles that we might want to set that helps us with this going forward. In terms of stroke, I know we kind of received the stroke improvement plan, the GIRFT report, and I know this also went to the Finance Performance Committee, I think it was. But again, real need for us now to focus on some of those stroke pathway improvement. It'll be a key focus of our work, particularly under the urgent and emergency care. And on the back of the stroke centralisation of rehab and the opportunities we know at the front door for better access to those. And then the only other one I wanted to pull out is we had a really useful session. Tracy's obviously in the role commissioned the work with the joint needs assessment, trying to pull all bits of data together. It's quite a unique piece of work, pulling lots of data sources together. And we had a little sample of that, and it's really was kind of a different place to what we've seen before in Wales. So again, it was another area where we thought might be useful for a board session to share some of that. I know she's looking to develop, but it really gives you insight into some of the population issues and then how they'll feed into the needs. But it really was quite a unique public tool that I'd not seen before. So looks into housing and all sorts of so I think we got that scheduled around. Yeah, so just kind of beginning of February. So we'll look forward to sharing that. But it's one of those things, if you've got time, you could spend lots of time navigating your way through this database. They were the only three things I wanted to pull out. Obviously, as you can see, it's a busy agenda, and we continue to try to find time out for kind of more informal meetings as well as the formal business.
Yeah, which are really important.
Yeah.
Thank you for that, Nicola. Are there any questions, Nicola? No. Thank you. Overview of the joint committee activity.
Yeah, so there's the standard reports. There's nothing of the significance I wanted to pull out this report. Other than just to note, obviously there's a lot of work going on around the new joint committee arrangements planned from April, but lots of work going on last week, lots of challenges to meet the timeline. So and then in terms of the East report, again, fairly kind of standard agenda, but it's probably worth pulling out the update on EMOOTs, you know, lots of concern, particularly around you know, some of the options are there, and therefore they redid some of the options of engagement work at the end of last year. Again, we need to keep an eye on progress with this one.
Yeah.
So that was the only thing I was going to draw.
Thank you. Are there any questions on WISC and EASC? Can I just ask then, to what extent the discussions between WAST and health boards is progressing in terms of their integration into community services, which is mentioned in the EASC report?
So in terms of the health board, of WAST, so we've got what's it called, the Integrated Commission ICAM, which is
Not integrated.
Non-integrated.
No, it's not.
Integrated Commission.
I'm being flippant. I'm sorry, Chair.
So that's there as a mechanism. But what we have done in the last 2 months is we've had a bit of not a full exec, but almost an exec to exec meeting. Because I think it's fair to say, because of the tensions in the system, sometimes the relationship isn't as tight as it needs to be. And I think Jason and I recognised that, and we came together as a team to really look at those opportunities of addressing some of these ambulance delays, and agreed a couple of some of the issues about getting people for a quick diagnostic and what we need to do so they would support that, looking at our ability to use the porta cabin outside for early release potentially, falls pathway. There's a lot of work James and clinical colleagues did on a falls pathway, and then they were sharing some of their experience around alternatives, other pathways that we're going to have. So we've had that. We've got another one due in the next week. So we've tried to strengthen our relationship at a senior level, which I think from some of our reflections is possibly more effective than what the ICAP meeting was, albeit we've also got operational level meetings where we meet weekly around various issues the operational teams facing day to day. But we've tried to put a more strategic meeting in, I think, to address bigger challenges. Is there anything you want to add to that, Leanne?
No. Thank you. Helpful.
I think, for us, which we probably don't spend enough time, because we spend a lot of time on handover delays, understandably, is the opportunities to reduce our conveyance rates.
Right.
And to make sure we're only bringing, people who need to be to the hospital. I know that's an area that we are keen to do much more work on.
Yes, there's a piece of work in progress. So we've had an improvement collaborative with WAST in the autumn. There's a further event on March the 7th with external facilitation. And this week there's a meeting with WAST to look at some of the detail around the opportunity. Yeah. So the 3 pathways are falls, respiratory and chest pain.
Good.
As well as the work we're doing on frailty, which very much is involved WAST.
That's good. Because we do need to make progress and get a bit of consistency.
They have one of the highest conveyance rates in the UK.
Yeah, I know.
It is interesting. And going back to the discussion we had on the finance earlier, and it's one of those things where I'm trying again to capture what's different about the demographics, demand. So we are the second biggest health board next to Betsy. But just taking last week's, each Monday we'll send a kind of calls report, and red calls, they're a small proportion, they're only about 4%, I think, of calls, maybe a bit bigger, higher now, isn't it? We had 259 calls, red calls last week, so they're more seriously. And the next to that was Betsy, 215. and somewhere like Cardiff and Clontarf that are, you know, slightly smaller, so we're around 150 odd. So 100 more red calls than our neighbouring health boards that are slightly smaller, but not that much. You know, and I think at one point we had 9 active red calls at one point last week. And when they cluster like that, when you look at the average across the week. So, and again, and it's something I'm quite keen to work with WAS to give some insight into, you know, into what you're seeing around demand and whether there's a variation on what, because again, it's just helpful in us to understand why is that? Why are we having so many more red calls? So, so it's just, yes, Penny.
So is it something to do with demographics? Thinking of Monmouthshire, you know, more over 80s than anywhere else.
Yeah.
The only thing I would say is that, you know, we're not that different from fact demographic, and our ambulance demand one day last week was the same, more than Cardiff and Clontarf combined. You know, to give you an idea of the demand. You know.
I'd be interested. I'm sure there's no way of knowing. It's in my head. I'd be interested to know where the majority of those red calls came from. That's all.
Yeah. We can.
And if it was Monmouthshire, it would be quite interesting to see if it's demographics were involved.
Who determines whether it's a red call? Not the
last week triage.
Do they?
Yeah, through us. So
it's a triage through a process through something called AMPDS, which is an American triage system. It's the triage system is renowned for having a high failure rate. So over triaging a number of patients, that's particularly in the breathing difficulties category, because it's a system that, you know, it's a non-clinically qualified call advisor going against a system of triggers based on what someone says.
So it couldn't be a.
Somebody saying this is
Somebody saying it's a red call, so it's not a user issue.
No, it's not a user issue. But if you use particular words, that will trigger a red call, and members of the public will learn
what words.
Particularly if they're frequent callers, the trigger words to use. So if you say you're struggling to breathe, you'll get a red ambulance.
It's
an incredible difference.
It's not Monmouthshire, it was 23 of the 257. And you would expect, because it's a smaller population.
Yeah.
The biggest number of calls were coming from Cyfrwy and Newport, which are our two biggest. So it's probably quite relative.
Was that the cold weather as well? Was that the ice time?
Right.
I can't even remember last week. Something was with me.
I suppose it's the inconsistency across health boards. So there's something about seeing a peak, and sometimes you'll see the whole of Wales will see the peak together because it will be linked to the weather. But you know, it's interesting. We do stand out as an outlier. Great call.
And who handles the call? So do we have a Gwent call centre and a Cardiff call centre, or is it a ferry lines?
Wales.
Yes, I'm sorry.
Yeah, north and south.
So West
Three. There's one in Carmarthen as well as just
a lot of ambulance experts from this table. Hannah and Jen.
I could wax lyrical for 2 hours probably about the inefficiencies in ambulance systems. We're not for today.
We have seen a spike in acuity though, sort of off the back of those red ambulances. One of the team were on call on Saturday, took 4 cardiac arrests into recess pretty much at the same time. So there are some pretty poorly people out there at the minute. I think some of that will be definitely weather related, patterns of presentations, but we're exceptionally unlucky, I think, to receive those individuals at one time. Probably exceptionally lucky for those guys, but it places the teams under a huge amount of pressure in terms of release of recess space to be able to provide the care for the patients that need it most.
Yeah. Well, we shall return to this.
Yeah.
Thank you. So key members for 10, key matters from the committees of the board. The chairs, are there any issues you want to bring to our attention? No? Okay, thank you very much. And any other business? Is there any other business? No. Right. Well, the date of the next meeting is the 27th of March, and we will go straight in, if I might, to the confidential